A warm good evening, everyone. Thank you so much for joining in. It's a wonderful Sunday again. We're back with the second episode of the International E-Conclave on Oral Cancer. Today, this year's theme is capacity building for oral cancer, and it's far more exciting because when we had the first E-Conclave last year, it was more on understanding the intrigues of oral cancer, and this time we are uniting and synergizing with multiple institutes all together across the country to really create a difference and to have a good capacity so that we can reach the masses, we can serve those patients out there who really need our help together. I would like to thank all the partnering organizations who have really helped us make this event successful and have joined us today from across the country. I take this privilege to quickly introduce the dignitaries of the inaugural ceremony for today. We have with us our chief patron, Dr. Anil, who's currently president of UICC and also the director of Oncology from Apollo Hospitals. Dr. Himanshu Pandya, or represented by Dr. Rakesh Rawal from Gujarat University, Dr. Somesh Chandra, Director of Sterling Cancer Hospital, Dr. Alok Thakar, HOD of ENT from AIMS, and Governing Council member from Foundation for Head and Neck Oncology, Dr. Prathamesh Pai, who currently President of the FHNO, Dr. Arun Goel, Senior Director Surgical Oncology from Max Hospital, and Professor Rakesh Rawal. The dignitaries, the other dignitaries who I would like to introduce and welcome today on this evening is convener Dr. Pawan Gupta, founder of ICanCaRe and also director of Head and Neck Oncology at Max, Dr. Rohit Nair, director of Head and Neck Oncology at Max, and Dr. Reena, Kumar, our academic director from ICanCaRe Academy. The lead organizers for the evening have been Dr. Arun P, Secretary of FHNO, Dr. Dushan Mandlik, Treasurer of FHNO, Dr. Kush Shah, Surgical Oncologist from Sterling Cancer Hospital, Dr. Rajat Saha, Associate Director of Medical Oncology from Max, Dr. Vikas Goswami, Associate Director from Max, Dr. Rashi Agarwal, Clinician and Radiation Oncologist, Dr. Manisha Pandya, Director of Women's Health Initiative at ICanCaRe, Dr. Keshav Nithani, Director from Denta Smile Max Noida, and Dr. Gitika Sharma, Commander of ICanCaRe East Delhi, and also convener for CDH IDA East Delhi. I would now like to introduce Dr. Pawan Gupta, who is currently the Director of Head and Neck Oncology at Max and also founder of ICanCaRe, to give the welcome address to the audience. So he has written numerous books and is running a lot of campaigns on Save the Youth, Catch Them Early, Chota Dana, which is for oral cancer, and has authored numerous books, as you can see on my screen. So I would quickly hand over the dais to sir to give the welcome address.
Thank you, Shruti, and thank you all dignitaries. It is a real pleasure for this to give this welcome address for the second International ICanCaRe Oral Cancer E-Conclave. The idea behind this E-Conclave is to connect with everyone across India and to be able to the what I call it as the king of all cancers, oral cancers, how we can actually tame it, and that's what we are looking for. And when we started this, actually, it is a real pleasure to say that I got a response from each and everyone across India. Whomever we connected, they were all enthusiastic, because I understand that everyone as an oncologist and even as a dental surgeons, they are facing this biggest problem, which is the problem for India actually. It's not the world's problem, it is more of a problem for India. So I welcome all of you for these 4 sessions where we will be dealing with how to deal with this, the king of all cancers, the oral cancers. Welcome everyone and look forward for enthusiastic participations from everywhere. Thank you so much.
Thank you so much, sir. That was really wonderful. Now we move over to lamp lighting. This is a digital lamp lighting. So I have put down all the pictures as the lamp lights. And now I will give the remote control to Anil sir, and I'll invite him on the dais to please inaugurate this session. Thank you so much, sir. So this begins the E-Conclave for the evening, and now I will like to invite Dr. Prathamesh Pai, currently president for Foundation of Head and Neck Oncology. Sir is also a professor of Head and Neck Surgical Oncology at Tata Memorial Center, Mumbai. A very versatile surgeon, has special interest in laryngeal and skull-based surgery with focus on laser and minimal access. Convener of the Multidisciplinary Skull-Based Clinic since 2007, member of the Institutional Review Board, Tata Memorial Center for several years, and is also a reviewer for numerous national and international journals. Has more than 60 peer review publications and co-editor of a monograph on survey for larynx and hypopharynx. I'll invite Sir to please give the inaugural address.
Thank you, Shruti, and thank you, Dr. Agarwal, for this, Pawan Gupta, for this invitation. The ICanCaRe, the second edition, the theme is the capacity building for oral cancers. And that is basically the mandate of the Foundation for Head and Neck Oncology, which seeks to disseminate the knowledge for head and neck oncology practice across the country. And we have with us a very fantastic 4 sessions, which will aim towards that and encourage more of the youth to participate in this treatment. And I would like to encourage more people to participate in this. Thank you very much and welcome to this inaugural session.
Thank you so much, sir. And now I would like to move ahead and invite Dr. Somesh Chandra. Sir is currently Director of Head Surgical Oncology at Sterling Hospitals and Sterling Specialty Clinics and Cancer Center. He's also the Section Editor for Head and Neck IGSO, past Associate Professor of GCRI, EC member of ISO, and Director of KCHRS Goraj Baroda. So I'll invite Sir to kindly give his address on Intrigues of oral cancer and why is this important for us.
Greetings and welcome to all the dignitaries on this digital platform. And this is the second edition. The first edition was during COVID times, and we know that COVID has gone, or at least the ferocity of COVID has gone, but the ferocity of oral cancer and head and neck cancer continues to rage all across our nation. And last year we had a very nice experience of involving all those who are involved in the care of these cancers, the oral specialists from dental, maxillofacial, the ENT surgeons, the oncologists, and so we thought this was the proper format to carry on. And I'm sure in these coming 4 sessions will add to whatever work we could do last year and also carry it forward for the next year. Thank you.
Thank you so much, sir. And now I would like to invite Dr. Alok Thakar. Sir is currently the HOD of ENT department at AIIMS and also a member of the Governing Council for Foundation for Head and Neck Oncology. Has been a consultant surgeon at the All India Institute of Medical Sciences as well. So I would like to invite sir to talk about how the vital collaboration on oral oncology can help us reach out to the periphery.
So thank you, Shruti. Thank you, Dr. Gupta, and of course, Dr. Somesh Chandra. So the FHNO collaborated with this last year, and I think we set out with a great theme of 4 seminars undertaken virtually. Perhaps COVID forced a hand to work virtually, but it's proved to be a great way to connect with so many people all around the country. I think we set very high standards last year, and with the high standards that was set, I think expectations are high. And now that expectations are high, obviously this year we hope and expect we'll do better than last year. So congratulations on the success of last year, and of course let's hope we can build on it as we move forward. This forum has many unique features. I mean, there's a greater emphasis on rehab, there's a greater emphasis on prevention, not just homilies towards prevention, but real practical care and points about prevention and tobacco control. So it gives a lot of value. So all the best.
Thank you so much, sir, for the kind words. And now I would like to invite Reena, ma'am, Academic Director of the ICanCaRe Academy, to talk about the ICanCaRe's perspective and how we are making an attempt to define oral cancer.
Thank you, Shruti. So at the outset, on behalf of ICanCaRe, it gives me immense pleasure to welcome our honored dignitaries, accomplished faculty, chairpersons, moderators, quiz lead, quizmaster, and very importantly, our very valuable delegates and viewers to the second International Oral Cancer E-Conclave, which is being spread over 4 weeks with the theme Capacity Building for Dealing with Oral Cancers. As we all understand, globally oral cancer ranks very high amongst the cancers, but in India, it is like one of the killer cancers, and we have around 77,000, I think, new cases and a huge number of deaths annually. So with this kind of a scenario, where we have, a potential pre-malignant lesion there before it actually turns into malignancy. And also we have numerous risk factors, whether it is tobacco consumption, whether in smokeless or other forms, and the smoking forms. We have the nutrient deficiency diet, we have oral hygiene issues, we have viral infections, we have everything. So considering all of this, there is a need, because this conclave comes out of it that there are risk factors, there is a demand in this country, and there is a healthcare demand which is like a global demand coming up, and in a pressure like in country like India, where the economic transitions are happening. I think the demand on healthcare is very, very high. So at ICanCaRe, we realize and recommend that capacity building to redefine oral cancers is only with a multi-pronged approach. It cannot happen any other way. So the first week, we would say making prevention and early diagnosis of oropharyngeal cancers as a mandatory universal responsibility for every healthcare professional. The second approach is to actually catapult dental surgeons and ENT surgeons in the forefront of the capacity building campaign, because we as by default, we can visualize and examine the oral cavity of every patient who comes into the clinic. The third capacity building strategy would be upskilling every healthcare professional to conduct an oral screening, because we know that oral screening is one of the simplest and the easiest ways. And of course, not just do it, but educate and empower every patient who comes into the clinic to be able to examine their own oral cavity. That's a very important part, self-examination. The next strategic approach would aim at creating tobacco cessation specialists in all healthcare domains. I would say that the one before the penultimate capacity building strategy is to create research teams, because unless we work to innovate, as the need of the hour is to manufacture simple, portable, financially viable but reliable equipment, especially for mass screening, for recognizing this early pre-malignant lesions and oropharyngeal cancers, developing biomarkers, lab on chip to facilitate an early detection. And the sixth and the most revolutionary capacity building strategic approach, I would say, would be harnessing digital technology, smartphones, machine learning, and artificial intelligence to create algorithms for decision making. Dear colleagues, friends, everybody, I think the time is right that we respond to the wake-up call to reconceptualize, recontextualize, reassess our strategies to redefine oral cancers by being agile, action-oriented, incorporate critical thinking, be innovative and collaborative to get the entire healthcare workforce focused on oral cancer. Education and advocacy forums like this Oncology eConnect is definitely a step towards this direction. I wish you all great deliberations, learnings, and sharing at the second International Oral Cancer Conclave, brought to you by ICanCaRe in collaboration with Gujarat University, Foundation for Head and Neck Oncology, and Sterling Cancer Hospital. Let's have a great learning and understanding of this deadly disease together. Thank you, Shruti.
Thank you so much, ma'am. I think that was really powerful. And with this, I would now like to invite Dr. Rakesh Rawal, representing Dr. Himanshu Pandya, the Vice Chancellor for Gujarat University. Dr. Rawal is the Professor of Life Sciences, the Professor of at the Department of Life Sciences, Coordinator for the ICanCaRe Tobacco Cessation courses, and also the Coordinator from Department of Biochemistry and Forensic Science. Sir has more than 116 national and international research publications on his name. So I would now invite Sir to talk about how the streamlining the intervention can be helpful for all individuals.
Namaskar. So, on behalf of our Honorable Vice Chancellor, I am going to read out his message which he passed on today morning. Honorable guests, esteemed resource person, and dear participants, on behalf of Gujarat University, I welcome you all to the second International Oral Cancer E-Conclave starting from today. I appreciate the efforts put forward by ICanCaRe and other supporting institutions who have joined hands in the fight against tobacco-mediated cancers. In spite of being the leading cancer in India, oral cancer is still a most common preventable form of cancer, as the etiology is known and the site is easily explorable for screening. So I urge all the participants and partnering institutions to join hands to form a network for collaborative research and capacity building for early diagnosis and prevention of tobacco-mediated cancers. I'm happy to share that Gujarat University is ranking first in the state and top 50 university of India as per NIRF ranking. And we have the state-of-art cell culture facility, genomics, proteomics, and metabolomics core facilities in our campus. Gujarat University have endorsed certificate course on tobacco cessation specialist offered by ICanCaRe and few more courses uh, because of its uniqueness, well-structured curriculum, and the scientific approach. I once again thank the whole organizing team for making me part of this event, and I wish every success to this E-Conclave. Thank you.
Thank you so much, sir. That was really wonderful again to hear such nice words of motivation from Himanshu sir as well. And now, ladies and gentlemen, I would like to invite Professor Anil D. Cruz, the chief patron for the event. Sir is, what do I say? There's no words to define it because all of us know who he is. He's currently the president of UICC and also director at Apollo Hospitals. Sir has served as editor of Manual of Clinical Oncology, has numerous pivotal contributions, which is more than 500 plus peer-reviewed publications, more than 1,000 lectures and 100 named orations, plenary lectures, and keynote presentations around the globe. And I'm so happy to share that Sir is also a staunch supporter of ICanCaRe. With this, now I invite Sir to give his address.
Good evening, everybody. Thank you, Shrutis, dignitaries who are part of this program, esteemed faculty, delegates, or if I can say, all those attending today's program who are committed to the fight on oral cancer, welcome to the second edition of the International Conclave organized by ICanCaRe on oral cancers. I'm humbled and I'm honored that you all have called me yet again to grace this lovely program, participate as a faculty, as well as attend the sessions. As has been said by all speakers, we know that oral cancer is a global problem. Over 300,000 cases globally. Unfortunately, half of them in our parts of the country, 2/3 locally advanced, and over half the mortality globally, again in our part of the country. What is worrisome is that over 70 to 75% of people who succumb to this disease succumb during the productive years of their life. These deaths are before the age of 70, which is more or less the national average for mortality. These are people who should be in the prime of their life, contributing to the economy and growth of our country, and unfortunately they succumb to oral cancer. It's paradoxical because, again, as Reena and various others said, oral cancer has a well-defined tumor progression model. It takes a long time before it comes into a locally advanced stage, and also that the oral cavity is amenable for examination by one and all, by the patients, by the oral cancer specialists. But again, as Reena said, by dentists, physicians, whatever problem they go for to a doctor, they normally say, Jawbone dikhao, put your tongue out, open your mouth. So it's really paradoxical that we find these cancers so late. I want to congratulate the entire team of ICanCaRe, Pawan, Shruti, Reena, Rishabh, Harshita, for this great initiative, co-hosted by the Gujarat University and Sterling Hospitals, led by Dr. Somesh Chandra, and a national body, the FHNO, represented today by Alok, Prathamesh, and Arun. Only if we join hands all together will we be able to tame this king, as Pawan calls oral cancer. But to me, we don't have to tame it. I think we have the ingredients to eradicate this disease from the face of our part of the world. Now, the ICanCaRe, I'm touched and I follow your work. And once again, congratulations. You all have dedicated the initial part of your work to training, capacity building, which is great. I gather you all are going to expand into service. And I would urge you all to do something towards research. This is a cancer in our part of the world. We don't need to read Western literature. There have been a lot of contributions in the recent past from our part of the world. And I just encourage all the youngsters listening to us today to not only treat, diagnose early, help our patients, but also research and teach the world how we can truly tame this cancer. I end because I speak today both as a UICC president and as someone who's dedicated his life to head and neck cancer. So I have a passion to treat, do well for my patients. I also have a passion for cancer control. And it will be incomplete on this address if I don't once again reiterate the importance of tobacco control. And I know many of us who I can see today on the screen do some part of tobacco control. But again, I congratulate ICanCaRe for the efforts on tobacco control. It's something that we can prevent. 42% of our countrymen use tobacco in one form or the other. And I think each one of us should make efforts. World No Tobacco Day is just around the corner, end of May. And I think our efforts should be directed towards tobacco control as well. So with these few words and without much ado, I hand back to the organizers. Thank you very much for this opportunity to be part of this great initiative. I wish you all great luck, great deliberations, and all the best for the future. Thank you very much.
Thank you so much, sir. I think this again inspires a lot and gives us a lot of encouragement and enthusiasm to keep going and to keep working and to join hands together to really tame, as you said, to tame the disease rightly and show to the rest of the world that yes, there's something is available here as well. So with this now, we come to the end of the inauguration session, and I would now like to invite Dr. Arun P. Sir is currently serving as Secretary of the Foundation for Head and Neck Oncology, is also a Senior Consultant for Head and Neck Surgery at Tata Medical Center and Cancer Hospital at Kolkata. Sir has been the member of the team managing a biorepository for cancer specimen for future research at the center, has more than 40 publications to his credit, is currently working on 9 ongoing research projects, which includes isolation of human oral cancer stem cells and cancer-associated fibroblasts from patients' tumors, and establishment of its primary culture, has interest in head and neck surgical oncology, tissue banking, and stem cell research. So I hand over to Sir to kindly give the thanks.
Thank you, Shruti, and a very good evening to all of you. I must congratulate Dr. Pawan Gupta and his team for organizing this meeting. But as it started out, initially, I thought it is a big program. It stretches over 4 Sundays, and I really didn't have a sense of what do we do on 4 evenings. But as the mails kept coming in, as the program began to take shape, and it became very clear. And it was a big program because we have a big problem at hand. And I realized that the program was tailored in such a way that it was not just surgery, something like we are more used to, but the issue that we have in hand is of a larger magnitude and also multi-pronged. So, ladies and gentlemen, the ICanCaRe E-Conclave will not only deal with surgery or radiotherapy and medical oncology, but it will also touch upon subjects which are rarely discussed at head neck meetings, and that would be tobacco cessation, early detection, and even rehabilitation. So it's well justified that we use 4 Sundays for creating this comprehensive program. And thank you for involving the FHNO. You had this association last year as well, and we are very happy to be part of it this year. I must thank all the dignitaries who spoke before me to have come and graced this occasion. And they have really lit the lamp, like, Dr. De Cruz lit the lamp, and he has lit that passion for knowledge among so many of us who are here to listen to the proceedings. So we are about to begin our scientific session, and let's all go and delve into it. And thank you so much for having me.
Thank you so much, sir. It is a great pleasure to hear you, and it actually creates a lot of the passion to run and drive the cause. So with this, we come to the end of the inaugural session, and now we move ahead to our scientific sessions. We're going to have 4 scientific sessions in this evening, followed by a panel discussion and a wonderful quiz competition, which will result in numerous prizes towards the end of the E-Conclave. So I'll request all the participants to stay tuned, enjoy the session. If you have any questions, please keep it at hold, ask on the chat box. The moderators and specialists are available for answering those questions, and wait for the quiz to happen towards the end of the program. Now, I would like to invite Dr. Rajat Saha. Sir is the moderator for the scientific session, for the first 2 scientific sessions. Is currently serving as Associate Director of Medical Oncology at Max Super Specialty Hospital. Has multiple areas of interest, including cancer care oncology, head and neck oncology, musculoskeletal oncology, uro-oncology, gastrointestinal oncology, medical oncology. Has been a European certified medical oncology, a member of the ECMO, and member of the European Society for Medical Oncology. Sorry, I have repeated, I think. He's also an investigator in phase 3 international clinical trials. So with this, I hand over to Sir to take the scientific sessions ahead.
Thank you very much, Shruti, and I thank Dr. Pawan for giving us the platform to definitely discuss a very menacing cancer in this part of the subcontinent. And to begin the scientific sessions, the first scientific session is on oral lesions and understanding osseous invasions and choosing the optimal imaging tool to actually diagnose the osseous invasions. And the chairperson for this session is Dr. Manish Munjal. He's a senior consultant in ENT at Sir Gangaram Hospitals, with numerous publications on voice as well as head and neck surgery. He's currently serving as the president of Laryngology and Voice Association of India. He's also the founder member of the Asia Pacific Voice Association, and he has been invited as a faculty at major conferences around the world. In the same breath, I would also like to invite the speaker for this session, Dr. Vishal Dang. He's a very decorated speaker. He's a visiting professor at the University of Detroit School of Dentistry at Michigan, USA. Extensive teaching experience, about 24 years of experience, and that's why he has been invited to enlighten us on this topic. And he has been an MDS examiner and also has published numerous books, and he's the past president of IAOMR. Without much ado, I will start with my presentation. At the outset, I must thank the organizers, Shruti, who I've just heard now, and she's been in touch on the email, Dr. Reena, who's a very dear friend, and Dr. Pawan Gupta, the force behind ICanCaRe, whom I have known for several years, but we don't meet often, but I know how passionate he is about tobacco cessation and, education. So also a big thanks to the Gujarat University and the Head and Neck Oncology Foundation, serving hospitals to bring this event together. So I'm the opening batsman, I presume, and Dr. Munjali, the chairperson, and Dr. Saha, thank you so much for your introductions. So as an opening batsman, I'm not really worried about the ball which I'm going to face, because the scourge of oral cancer hits me right in the face. I know what we are facing and how to sort of, how to manage this disease is a big challenge. So my presentation is actually confined to understanding something about how invasion occurs in cancer, but more importantly, how to choose the tool for imaging. Unfortunately, we don't have very clear-cut protocols which are sort of accessible to all the practitioners as to how imaging should be done when we talk about diagnosing a suspected case of oral cancer. So before I start with the topic sort of per se, we have talked about capacity building, which is the theme of this event. Now, as a dental surgeon, my presentation is sort of focused from the dentist's viewpoint, because I think we are at a very advantaged position.
and we can do much more than what we are doing. And it's our job to see that the younger people entering the profession, their training and their subsequent practice helps us to control oral cancer as a part of a big multidisciplinary approach. I mean, we are part of a big team of healthcare workers. We must understand the importance of our role in this big ocean, if I may call it. We have a huge number of dental colleges, a huge number of registered dentists. It is the highest in the world, you know. Today, we have the highest number of registered dentists, almost touching about 3 lakhs. We have a huge number of graduates coming out each year. And even our dentist to population ratio today is not too bad. But the problem is that we don't have the dentists at the right places. We have them, confined to the metros and not in the areas where perhaps they can make a bigger difference. Now, can we do more than what we are doing? As Dr. Reena mentioned, that we have approximately 77,000 new cases of oral cancer being diagnosed each year. When I say oral cancer, I'm talking of oropharynx and oral cavity proper. So I'm not talking about the other surrounding areas. And we have over 50,000 deaths per year on account of oral cancer. So there's a huge opportunity and there's a huge challenge, for a dental surgeon. Now, the opportunity is that as was just mentioned, that we can actually see the mouth of every patient that we are examining for dental work. We are also critical, not just in dental disease identification, but we are also a very important, force which can be used for tobacco cessation activities. We are also a very important group of doctors who may contribute to upkeep of oral health of the patient prior to treatment for oral cancer, during treatment and post-active treatment of oral cancer. And of course, subsequent surveillance, which is required to identify recurrence, also can be perhaps best performed by a dentist who calls his patients every 6 months for a checkup. So we have a very strategic role to say, in this entire process, right from prevention to early diagnosis to pre-treatment planning of dental care, ongoing treatment care for the mouth, and post-cancer management care, rehabilitation, and a surveillance for recurrence. But there are some challenges. I've been teaching for so many years, and I find that when a student joins dentistry, he is somehow, geared up, he's programmed to just see the teeth and how he can work on the teeth, give relief to his patients, and earn his bread and butter. But we, as oral medicine specialists or oral physicians, we are, we must train our students to examine the entire oral cavity and not just confine to a patient's complaint when he visits us. We can motivate the patients, and we need to do more in this regard in tobacco cessation. Now, why is it that dentists perhaps don't identify as many cases of oral PMDs and early cancer as they should? I think that some sort of incentivization is also required in a larger way for the normal dental surgeon as to why should he go into this area of cancer prevention, tobacco cessation, early diagnosis, and very importantly, that even today I find that there's a lot of confusion in the minds of the dentist as to what are the guidelines and the protocols for referral. What should he do when he suspects, a patient to have a potentially malignant disorder? We get referrals, but somehow there's a fear, psychosis, there's a bit of, clarity missing, if I may say so. And when a patient is referred by a dentist to an oncology center, there must be a system of a reverse feedback for the dentist so that he can, at the end of the day, have that satisfaction that performed a small part in this big jigsaw of oral cancer. Now, as we know that oral cancer could be an exophytic or endophytic growth. In fact, the ICanCaRe, brochures, they talk about a chota dana as the first sign of oral cancer. I was just wondering, is that chota dana enough, I would say it could be a ghav, it could be a dhabba, or it could be a dana. So, it could be an ulcer, or it could just be a patch, or it could be a dana. And anything could represent something which is as, harmful as a malignant disease in the mouth. So these are just some pictures. I am just going to move fast to save on time and coming to the main area. We do have situations like this where a white patch, now if this sort of a patient reports to a private dentist, perhaps the dentist is not sure what he's seeing, and so he must be clear in his mind that what is the protocol of examination, of history taking, and also of referral if he suspects oral cancer. Now, oral cancer is not just squamous cell carcinoma. We also have other varieties of, cancer, and this patient was one who presented with low-grade osteosarcoma. So when you talk about diagnosing oral cancer, at somewhere at the back of our mind, we also need to keep other cancers in mind, which can be seen in the mouth. Now, when we talk about oral cancer and bone invasion, see, invasion or spread of cancer can be a direct extension to the neighboring structures, or it could be an erosive or an infiltrative entry into the bone. And this part, bone involvement, is important because it has both therapeutic and a prognostic importance. So when we talk about jawbone involvement, it is usually the gingival carcinoma which is in direct contact with the alveolar process and often is not diagnosed early enough. The problem with oral cancer is the poor survival rate of under 50% is on account of the fact that diagnosis does not happen in the early stage. Unlike breast cancer and even cervical cancer, where I think the medical profession has succeeded more, but in oral cancer, sometimes there may be confusion. There may be a confusion vis-a-vis the differential diagnosis. Somebody might think it's a periodontal disease or a pyogenic granuloma. It's just some other white lesion which may not be cancer or a potentially malignant disorder. So sometimes the diagnosis gets pushed by not just a few days but by weeks and months, which may be quite critical to the outcome of disease for that particular patient. So what is, after all, the aim of imaging in oral cancer? The aim of imaging is primarily it is for staging of the tumor, and we have to stage the tumor. We have to do a node staging and also understand if there are any distant metastasis, and even subsequently for follow-up after the treatment has been completed, we need to have some studies which can be compared with the pre-treatment, images. And so the question arises, what should be the optimal imaging tool, which was the gist of the topic proposed to me. Now, you can't answer this question in a very simple black or white way. The optimal imaging tool would depend on many factors, and a tool is only as good as the doctor who's using that tool. So if this tool is in the hands of a dental professional, then it would be probably different from the approach taken by a oncology center, where if a patient goes direct to the oncology center, the imaging proposed would be with a different protocol. But I'm trying to bring the two streams together, and I'll propose what I think is the right way of proceeding. So for primary tumor assessment, if you are talking about oral cavity and other higher tumors, I would say as a dental surgeon, because taking care of the mouth and the teeth is anyway very important, because the teeth have to be treated, the gums have to be treated before you can start cancer treatment. So panoramic radiography and intraoral radiographs are very important tools for screening initially. And they are easily, available. The cost is not much. And we also have now something called cone beam CT. So a dental surgeon is somehow more comfortable with these tools of imaging as compared to, say, a CECT or an MRI. But still, having said so, the thumb rule still remains that the soft tissue extent of disease is perhaps best identified or understood with an MRI. Although a contrast enhanced CT may also sometimes be used, especially if you're looking at the chest subsequently. So you might want to just do a CT instead of straight away jumping to an MRI. But MRI, of course, is the gold standard for soft tissue extent of oral cancer, whether it is of the tongue or any other soft tissue site in the mouth. But when it comes to bone involvement or invasion, then there is a bit of a dilemma, or we have to decide what would be the optimal tool. Now, this is just a simple panoramic X-ray. Now, it could give a lot of information, but again, interpreting panoramic radiographs, this is a practice which is not followed across the country. Panoramic radiographs are not, interpreted and reported by all the centers, and so we don't get all the information which one can obtain from these radiographs. Whereas, if you're doing a contrast-based sort of CT study, you can study the soft tissue in a soft tissue window, you can study the bone in a bone window, and you can understand the extent of disease, the invasion of the bone. And invasion of the bone is important because if the bone invasion is confined to, say, the cortex, or it's just the erosion of the cortex, such a tumor cannot be classified as a T4 lesion. So, for example, if there's a extraction site and a superficial erosion is seen at the extraction site of suspected cancer, we can't put it as a T4. For T4 involvement, there has to be some invasion into the spongiosa, into the medullary bone. And the moment the tumor goes into the spongiosa, then the prognosis, the survival rates are affected, adversely. So it is important to catch the disease before it reaches that T4 stage, before that bony invasion. And if we are talking about the maxilla, the antrum, for example, the sinus, if it has to be studied for invasion, then right in the beginning itself, we can choose a CECT to say a CBCT or an MRI, because bone involvement is better understood using the CT images. But a CBCT is also very effective sometimes and can be used especially in the dental scenario, because dentists somehow seem to be more comfortable with CBCTs since they are using them more often. Now, if you're not seeing any change in the CT or the CBCT, and you want to pick up a very small change in metabolism of the cortical bone, then a radioactive isotope scan or a SPECT scan may be useful. And this is also in the absence of a primary. If you don't see a primary on your MRI or CT, then perhaps you need to do a PET CT scan and try to identify the primary. You may have a case where there is suspected metastasis in the cervical nodes, but you can't see the primary in the mouth. So in these cases, you may need to do a PET scan to identify the primary. So when you are doing a radioactive isotope scan, it is important to remember that gum disease, periodontal disease can also indicate certain areas of increased, radioactive isotope uptake, which must be kept in mind when we analyze these radioactive isotope scans. For node assessment, I would say that the CT, MRI, and even the ultrasound are good modalities of imaging. It all depends on in whose hand that particular tool is. An ultrasound is good because it's very fast, it's very easily accessible, and it is quite cheap. So all these advantages are there, and it can sometimes give information as good as a CT or an MRI. In fact, 20% of occult nodes which are not examined clinically, will show nodal metastasis on some form of imaging. This sort of statistics is very important and must be kept in mind when we examine the patient clinically. And of course, I just forgot to mention that when you're talking about nodes, for metastatic nodes, it is the size of the node, the minimal axial diameter of the node, even more than the structure and surrounding infiltration, which is considered to be sort of the gold standard. If it is more than 10 millimeters in size across the minimal axial diameter, except for junctional nodes where it's 15 mm. In these cases, we would consider a nodal metastasis to be positive. And if we are wanting to rule out metastasis to the chest, for example, if it's a T1 disease, we don't even need to do a CT scan. The accepted sort of norm is that an X-ray chest may suffice to rule out metastasis, a normal X-ray chest, APU of the chest. Whereas if we are staging it as T2, then we may need to do a CT scan to rule out metastasis. And also sometimes you find a second synchronous malignancy, you might find a bronchogenic carcinoma in addition to what you're seeing in the mouth. So follow-up imaging for, I'm just about to finish, another minute or so more. So when we follow up imaging to sort of exclude recurrence of disease, this protocol should be that the method used should be the same as what was used before, because comparison is very important for understanding how recurrence may or may not have occurred. And this is best performed about 2 to 4 months after the active treatment, not before 2 months anyway. So in summary, I would first say that in a dental setting, say a teaching institution or a big dental hospital setting, intraoral radiographs, panoramic radiographs, and CBCT may be the good methods of identifying involvement of bone, and these could be complemented by a subsequent MRI for soft tissue extension of disease, including assessment of the nodes. This is in the dental setting. However, if the patient has gone straight to the oncology hospital or to a cancer center, I think that perhaps the onco surgeons or the medical oncologists or the radiation oncologists, they will perhaps prefer the use of a CECT and MRI, or one or both of these, to move further in management of that particular patient in treatment planning. And ultrasound, as I said, is extremely useful. It can also be used for a fine needle aspiration cytology, but it all depends on the competence of the operator. And scintigraphy, as I mentioned earlier, are useful in detection of initial involvement of the bone, and when nothing is seen anywhere, or sometimes even when you're doing a follow-up, a PET CT scan is sometimes indicated. And so again, to emphasize that, we must have a clear-cut protocol of imaging in all cases, and we must have the same modality to follow up the patient subsequently. That which was used in the beginning of treatment. So as I would just always emphasize to my students that tobacco cessation is so well performed by dental surgeons, and in fact now the Dental Council of India has made it mandatory that all dental colleges should have a tobacco cessation unit in the college, where a specialist from the Department of Oral Medicine, which is the specialty which I represent, or oral pathology is in charge, and we actually are responsible for counseling of the patients and making sure that, tobacco cessation is very nice when you talk about it, but at the same time, the failure of converting a tobacco user to a non-tobacco user, that failure rate is very, very high, So even if you succeed in converting one tobacco user out of 5 into a non-tobacco user, I think you've done a good job. So that's at least a beginning. And as dental surgeons, we must pledge to make a bigger and a better impact to minimize the impact of oral cancer in India. Thank you for this time and patient hearing. Thank you so much.
Thank you very much, Dr. Dang. That was an excellent, informative opening session by you. And you definitely underscored the huge opportunity of the entire dental faculty for early diagnosis of the head and neck cancers. And you have seamlessly kind of highlighted the spectrum of investigations which are required, which are actually carried out right from the intraoral radiography and cone beam CT to the more advanced investigations which we are using, like CCT and MRI and PET scans. So an excellent presentation indeed, sir. move on to the next session, the second scientific session for the day. Now we'll be again delving deep into the optimal imaging for specifically tongue cancers. And to chair the session, we have Dr. M.K. Sunil. He is the professor and head at the Tirthankar Mahavar University, Dental University College at Moradabad. And he has got a huge 25 years plus of academic experience. He's a recognized PhD guide, numerous articles and papers in various national and international journals. And he has guided approximately 35 plus PG students in their thesis on forensic odontology. Welcome, Dr. M.K. Sunil, sir. And to enlighten us on this optimal imaging on tongue cancers, we have Dr. Deepal Shah. He's a consultant radiology at Sterling Cancer Hospitals, Ahmedabad.
Okay, good afternoon all. Today I am going to speak about the optimal imaging for tongue cancer. Tongue is the centerpiece of the oral cavity and has a crucial role in the taste, formation of bolus, deglutition and speech. So given the importance of the tongue carcinoma should be accurately staged in order to optimize treatment options and preserve organ function. So this is the table showing the difference in the T staging between the HSCC 7th edition and 8th edition. And as I have highlighted, depth of invasion is a new added criteria for the T staging of the tumor. Previously, extrinsic muscle involvement of the tongue was staged as T4A tumor. Now this criteria has been removed from the T staging. For the end staging, now extranodal extension has been added criteria, and if node is ENE positive, then it is staged as M3B. So, what are the modalities for tongue cancer imaging? They are MRI, CT, PET, and USG. So, imaging for the tongue requires modality with superior soft tissue characterization. So, MRI is the optimal modality, displaying anatomical details including intrinsic and extrinsic muscles, floor of the mouth, and lingular neurovascular bundle. CT has insufficient soft tissue characterization and is frequently hampered by the dental artifacts. So MRI is the ideal modality for imaging of the tongue. MRI can depict the T stage. It shows the extension of the tumor to the extrinsic muscles, encasement of neurovascular bundle, invasion of floor of mouth, extension to base of tongue, and the lesion crossing the midline. MRI can also detect the metastatic nodes, show their extracapsular spread, and invasion to surrounding structures. So given the all these details, MRI is the ideal modality. This information influence the prognosis and choice of the therapy, which could be single modality or multimodality, and also influence the extent of surgical resection that can vary from wide excision to partial glossectomy to total glossectomy, and it also influences the unilateral or bilateral nodal dissection. So directly coming to the MRI, this is the coronal T2-weighted images. I am showing the anatomy of the tongue, which is very well seen on the MRI as it has better soft tissue resolution. So you can see entry belly of digastric muscles, mylohyoid muscle, geniohyoid muscle, genioglossus muscle, sublingual gland, hyoglossus muscles. All these structures are very beautifully seen on the MRI. While to compare this, I have put one image of the CT scan. This is the case of CA tongue along the left lateral border with ulcerated lesion. You can compare this. All the muscles are not very well seen as seen on the MRI. Axial and sagittal T2-weighted images. You can see the anatomical details very beautifully on the MRI. You can see mylohyoid, sublingual gland, genioglossus, hyoglossus muscles. On the sagittal images, you can see classic fanning out of the genioglossus muscle. Even you can see intrinsic muscle like superior longitudinal and inferior longitudinal muscles. Now, as we have seen, depth of invasion is added criteria for the T staging. So, what is depth of invasion? Why it is so much important? Depth of invasion assesses the tumor invasiveness. It has prognostic value. More the depth of invasion, more the likelihood of nodal metastasis and local recurrence rate. So actually depth of invasion is a pathological measurement of the spread of the tumor below the basement membrane at the surgical resection. So this is distinct from the total thickness of the tumor. Tumor thickness is the distance from the tumor surface up to the deepest point of invasion, while depth of invasion is the distance from the reconstructed mucosal surface up to the deepest point of invasion. So you can see this is graphical representation. You can see for the flat tumor, depth of invasion and the tumor thickness are same. But for the exophytic tumor, reconstructed mucosal surface is like this. So depth of invasion is quite less than total tumor thickness. And for the ulcerated tumor, depth of invasion is significantly larger than the tumor thickness. This is a CT image on which I will show how we measure depth of invasion. So for that ulcerated lesion, we have to reconstruct the normal mucosal surface and we'll measure depth of invasion from the to the deepest point of invasion. Coming to the literature, this is the article published in AGNR in 2018. They have done radiopathological correlation for the tumor thickness on CT and MRI and its prognostic importance. And this study concluded that there is a very good radiological and pathological correlation for the tumor thickness, and radiological tumor thickness was predictive of the inferior survival. In this study, they have included 189 cases of the oral tongue carcinoma. For all these cancers, median pathological tumor thickness was 11 millimeter, while median radiological tumor thickness was 12 millimeter. So there is really very good correlation. They also correlated tumor thickness with the pathological tumor thickness and MRI tumor thickness with the pathological tumor thickness. And they also concluded that MR imaging showed better correlation. One more article published in June 2020 in ICanCaRe, that is MR evaluation of the tongue carcinoma in the assessment of depth of invasion with histopath correlation. And it has also concluded that MRI is the imaging modality of choice for the tongue carcinoma, and it has very high correlation between the MRI and histopath findings regarding the tumor thickness and depth of invasion. One more article again concluding that the MRI is the accurate method for measuring tumor invasion depth in the oral tongue cancer, and it has predictive value for the nodal metastasis for the oral tongue cancer. So now coming to the MRI cases, I'll show you a few cases. This is the case of biopsy-proven case of squamous cell carcinoma of the tongue. First image is the axial T1 weighted image. On the T1 weighted images, the lesion appear hypointense. Second image is the T2 weighted image. Axial T2 weighted image, the lesion appear hyperintense. You can see anatomical detail very well on the T1 and T2 weighted images. This anatomical detail is not very well seen on the star or diffusion weighted images. Third image is the star image. On this tumor appear very bright. The lesion shows restricted diffusion on the DWI imaging and shows low value on the ADC image. The last image is the post-contrast fat suppressed T1 axial image, and the lesion shows heterogeneous enhancement. So I'll show a few cases. These are the early cancers. First is the axial star image. On this image, there is very small lesion along the right lateral border of the oral tongue. Same patient with the contrast enhanced T1 weighted image. You can see the lesion shows enhancement. One more case. This is the star axial image. There is a hyperintense lesion along the left lateral border of the tongue. The lesion shows enhancement along the left lateral border. This is the T1 weighted post-contrast fat suppressed image. There is a enhancing lesion along the dorsum of the tongue. The lesion is maximum length of 1.6 centimeter, while its depth of invasion is 6 millimeter. As you can see, maximum depth is length is 16 millimeter. So if you have to stage this tumor according to the HSCC 7th edition criteria, this will be staged as T1 tumor. But in the 8th edition, depth of invasion is the added criteria. So as the depth is more than 5 millimeter depth of invasion, so this tumor is now staged as T2 tumor instead of T1 tumor. Few cases. First is the coronal T1 weighted image. On this image, you can see hypointense lesion along the left lateral border of the tongue. The lesion is abutting ipsilateral genioglossus muscle, but lesion is not involving the muscle. In the second case is the coronal T2 weighted image. You can see hyperintense lesion along the dorsum and left lateral border of the tongue. The lesion is extending right up to the midline. Lesion is also involving upper part of the genioglossus muscle. Third image is the biopsy proven case of right lateral border of squamous cell carcinoma of tongue. In this image, you can see hyperintensity on the right floor of mouth. Ipsilateral muscle is very well seen on the left side, while on the right side, the hyoglossus muscle is not visualized. So this image shows the involvement of the hyoglossus muscle. Last image is the coronal T2 weighted image. there is a very large mass involving the tongue along the right side. The lesion is crossing the midline. The lesion is involving bilateral genioplexus muscles. First image is the post-contrast fat-suppressed T1 weighted image, is coronal image. There is a enhancing lesion along the left lateral border of the tongue. The lesion is reaching up to the midline. These enhancing structures, which we can see in the floor of mouth, are the sublingual gland, and you can see the lesion is abutting sublingual gland. The second image is the coronal fat-suppressed T2 weighted image. On this image, you can see very large hyperintense mass. The lesion is crossing midline. The lesion is extending into the floor of mouth. Along with the lesion, you can see metastatic nodes on the both sides of the neck. As the lesion is crossing midline, this patient has metastatic nodes on the both the sides. Third image is a post-contrast T1 weighted image. There is a very large mass occupying almost whole of the oral tongue. Inferiorly, lesion is extending into the floor of mouth, and you can see this black structure. This is lingual artery. So the lesion is encasing lingual neurovascular bundle. Fourth image is the axial T2 weighted image. You can see hyperintense mass on the right side. The lesion is crossing midline. The lesion is involving bilateral genioplexus muscle, and posteriorly, when we see the posterior lesion is extending into the right oropharynx. This is the advanced case. Post-contrast T1 weighted images, coronal image and sagittal image. On the coronal image, you can see enhancing mass is extending into the floor of mouth. Lesion is crossing midline, and there are bilateral metastatic lymph nodes. On the sagittal image, you can see lesion is extending into the base of tongue. On these images, you can see lesion is abutting mandible, but there is no enhancement in the marrow of the mandible. So from this, we can say that there is no marrow involvement. MRI is the ideal modality to look for the marrow involvement. If marrow is involved, then the marrow appears hyperintense on the star images, and marrow will show enhancement on the post-contrast images. This is one very interesting case. MRI has changed the surgical planning in this case. This is coronal and sagittal post-contrast fat-suppressed T1 weighted images. You can see enhancing mass along the dorsum and left side of the tongue. The lesion does not extend into the floor of mouth, but we can see one enhancing nodule in the floor of mouth, which is seen on the coronal image as well as confirmed on the sagittal images. I have done sonography of the same patient, and you can see on the sonography hypoechoic rounded mass right adjacent to the lingual artery. So this is metastatic nodule, and this finding has changed the surgical treatment, and surgeon has to also extend the surgery into the floor of mouth, and this nodule was confirmed on the biopsy. Coming to the CT scan and PET CT, this is the sagittal and axial CT scan images. Post-contrast CT scan was done. There is very large mass almost completely occupying the tongue. The lesion is extending into the base of tongue. Lesion is extending into the floor of mouth, and in the floor of mouth you can see lesion is reaching up to the mandible, and on the bone window images you can see irregularity of the inferior cortex. So there is clear-cut cortical erosion by the lesion. On the axial images you can also see metastatic nodes on the both sides. PET images confirm the hypermetabolism in the entire tongue, also hypermetabolism in the node. So these are metastatic nodes, and the hypermetabolism also extends into the mandible. So this also confirms involvement of the mandible by the PET CT scan. Now, many of the patients come with the dental implants, which causes significant artifact on the imaging. So these are the few cases of the artifact. On this case, there is a very large artifact on the left side, but the patient had a hyperintense lesion on the right, along the right lateral border of the tongue. Well, in this case, there is significant artifact on the right side of the tongue, but the you can see enhancing lesion on the left side of the tongue. So, had the lesion been on the ipsilateral side of the artifact, we would not have been able to image this lesion, and we could not state the lesion on the imaging. Artifacts on the CT scan. This is the biopsy-proven case of squamous cell carcinoma of the tongue along the right lateral border. Coronal images CT scan shows significant dental artifacts. There is no diagnostic information on this image. Luckily, modern machines are come with the advanced softwares. So there is one software which is called artifact removal software, that's IMR. After applying that software, the images are reconstructed, and after this reconstruction, you can see enhancing lesion along the right lateral border of the oral tongue. To better delineate lesion, we have done rescanning of the patient with the open mouth, and now you can see very well entire lesion is very well seen along the right lateral border of the tongue. Now coming to the neck node metastasis, we all know tongue.
Come to the conclusion, sir. We are short. We have gone beyond the time, so please come to conclusion.
Yeah. Imaging also very important to find the metastatic nodes, and MRI is very useful to detect the extranodal extension like surrounding fast trending hyperintense sign, irregular enhancement, fast trending matted nodes. This shows metastatic nodes. So on post-treatment images, PET is very useful. Previous images show pre-treatment shows hypermetabolism. Post-treatment imaging shows no metabolism, so significant metabolic resolution. So for post-treatment imaging, PET CT is quite useful. So to conclude, even one more case where there is a post-NSAT RT, ulcerated smooth marginal ulcerated lesion along the right lateral border, while PET CT does not show any significant metabolism. So significant metabolic resolution. So to conclude, MRI is a imaging modality of choice for the tongue carcinoma, as it helps in accurate staging, tumor staging, including TNM classification, and it's which is crucial for optimizing treatment option. Thank you.
Good afternoon, everyone. And first of all, it's a privilege and honor to me to part of this international E-Conclave oral conference. And today's presentation, Dr. Dipal Shah is well narrated about the optical imaging of the oral cancers, and he has been briefed about early stages involvement, and he compared with above CT as well as to that of MRI imaging, and proved that MRI have shown the couple of cases. And to summarize, that the MRI is a very helpful imaging tool, particularly in early lesions to the advanced lesions. And it's a great presentation, Dr. Deepak. Thank you for all.
Thank you so much, sir, and thank you to both the speakers and chairperson for giving a wonderful scientific session. I would now like to invite Dr. Khyati Bhatia, who is the Associate Consultant at Max Institute of Cancer Care, also holding a degree in fellowship in head and neck oncosurgery, to be the moderator for the next two scientific sessions and take this ahead.
Good evening, everyone. Now we've come to the third scientific session for day one. And as the conference has been going on, it's been a great event. And I think the ICanCaRe team and Dr. Pawan, as usual, have done a fantastic job. I would introduce the chairperson first, Dr. Pravesh Mehra. He is the HOD and Director Professor, Oral and Maxillofacial Surgery at the Department of Lady Hardinge Medical College, Delhi. He's got a special interest in oral maxillofacial trauma, temporomandibular joint surgeries, orthognathic surgeries, and reconstructive jaw surgeries. He's been a senior resident in MAMC in the burn and plastic department, and he's also been awarded with great awards. And he's also the currently he is the president of the can't say this. Hello?
Yeah, ma'am. Past president of the IDA West Delhi branch. Sir is advisor to the WHO and Government of India on oral health and dental education, and currently on board for Task Force for National Oral Public Health Program.
So the speaker for today for this section is Dr. Rajarshi Banerjee. He's a consultant maxillofacial surgeon at AMRI Hospital. He's done his BDS, MDS and MOMS from Royal College of Physicians and Surgeons, Glasgow. And he's got a special interest in oral oncology with about more than 17 years of experience in the field. Over to you, Dr. Rajarshi. His talk for today would be...
I'm Dr. Rajarshi Banerjee. I'm consultant oral and maxillofacial surgeon in AMRI Hospitals, Kolkata. The topic of discussion today is adjuncts to diagnose oral pre-malignant lesions. Now, the lesions are white due to hyperkeratosis, acanthosis, and extracellular accumulation of fluid. And they are red because of atrophic epithelium, increased vascularization, and reduction in the number of cells. Now, the modes of diagnosis are to obtain a good clinical history, record the clinical presentation, a biopsy, cytology, and vital staining, telescope. Now, the red and white lesions are usually associated with tobacco. If they are not related to tobacco, example is lichen planus, and there may be oral candidiasis in immunodeficient patients, frictional keratosis from irregular teeth or dentures, and sometimes lichenoid reactions due to drugs or dental materials. The clinical presentations are either homogeneous or speckled. Oral pseudomembranous candidiasis appears as a white patch which can be removed with a cotton swab, partially at least. And these are the characteristic stria of lichen's, which is pathognomonic of lichen planus. In oral submucous fibrosis, the epithelium shows blanching and atrophy. Biopsy is a prerequisite for histological investigations, and it is actually the removal of tissue from living organism for the purpose of histopathological examination and diagnosis. We would do a biopsy when the lesion is present for more than 2 weeks and is refractory to therapy. Bony lesions with pain and paresthesia, with rapid expansion, persistent red and white hyperkeratotic lesions with change in color, and there is a suspicion of neoplasm and diagnosis of vesiculobullous lesions. It is contraindicated in very poor medical health of the patient, infections which are acute or pyogenic, and suspected vascular malformations or lesions like hemangiomas. The types of biopsy are like exfoliative cytology, brush biopsy, fine needle aspiration cytology, punch biopsy, incision biopsy, excisional biopsy, and bone biopsy. Exfoliative cytology is the study of cells shed from epithelial surfaces of various organs. They are collected via scraping, swabbing, or washing the surface. The stains used are Giemsa or TAP. This is done by a specially devised circular bristle brush. The access to all epithelial layer is present in these cases. It is a non-invasive method, and disaggregated cellular material is spread over a glass slide. This is how a brush biopsy of the cheek mucosa is done. Punch biopsy is a surgical biopsy done with the help of a punch, and it cuts a cylindrical piece of mucosa. This is the punch, which has a very sharp edge inserted into the tissues. Get a deep tissue material. This is how it is obtained. Incisional biopsy is regarded as the gold standard. It includes part of the lesion or part of the lesion plus affected mucosa. Usually a wedge-shaped specimen is obtained, and the disadvantages are tumor spillage, leaking of residual disease. This is how an incision biopsy should be taken. It is desirable that a narrow specimen which is deep and invaginating into the normal tissues is taken rather than a broad, shallow bit of tissue. In excisional biopsy, whole lesion is removed. The specimens are collected and fixed in 10% formalin solution. Fine needle aspiration biopsy is done with a needle which is 18 gauge attached to a 5 millimeter syringe. The area needs to be anesthetized and the needle is inserted to collect the aspirate. This is the apparatus for FNAC. It is also known as fine needle aspiration biopsy. The most representative part is to be selected, and the colored lesions should be removed en masse, and entire thickness of ulcers to be removed. If the lesion is less than 1 centimeter, we can go for an excisional biopsy, whereas a lesion more than 1 centimeter, we do an incisional biopsy. And the process before biopsy is to wash with 1% acetic acid, then application of 1% toluidine blue for 1 minute, then use a mouthwash, and the sample is taken from areas which are stained deep blue. Ideally, we should have healthy tissues at the margin for comparison. Before biopsy, the site should be prepared with quaternary ammonium compounds or chlorhexidine, and fixing is usually done with 10% formalin or 70% ethanol. Cytology is the interpretation of cells that has neither exfoliated spontaneously or are obtained from various organs or tissue by different clinical methods. The samples are easy to process and requires less desegregation. It is relatively easy to procure cytology sample. Multiple areas of tumor and lymph nodes can be collected for processing, and as cells are viable, so functional studies can be done. Some important cytological techniques are fine needle aspiration cytology, flow cytometry, and exfoliative cytology. Flow cytometry is a technique for counting and examining microscopic particles such as cells and chromosomes by suspending them in a stream of fluid and passing them by an electronic detection apparatus. This is the flow chart that is followed. The chemicals used. Staining is a vital step in histopathological and cytological investigations, provides vital details about the tissues and lesions. The most common staining mechanisms are H&E, PAP, and GAMSA. Now, H&E is hematoxylin and eosin, as we all know. Eosin is a red and pink stain binding to acidophilic substances like lysine, arginine. This is the gold standard for any histopathological staining. They work on the basic principle that acidic components has affinity for basic dyes and the basic ones for acidic dyes. Hematoxylin stains the nuclear part of the cell, whereas eosin stains the cytoplasmic part. Tapenicolou stain. Here is another popular stain that is used. It displays variation in cellular morphology, degrees of cellular maturity, and metabolic activity. This is an automatic stainer for PAP staining. These are the steps of PAP staining. The Bethesda system evaluates the following gradations. Negative is there is no unusual or abnormal cells. Atypical, there is presence of minor atypia. There are low-grade squamous intraepithelial lesions, high-grade squamous intraepithelial lesions, and cancer, which is a high probability of cancer warranting prompt and complete evaluation. May-Grunwald, that is GAMSA staining. This is a Romanowski type stain. In this, the immature erythrocytes will stain blue-gray, whereas mature ones are stained orange. Nuclei and micronuclei stain red to purple. This is a comparison between the Papanicolaou stain and the MGG stain. The parameters are nuclear detail, keratin demonstration, metachromasia, transparency, and background mucin or necrosis. Now, diagnosis of basic lesions on cytological findings. Lipoplexia is characterized by thickened keratin layer on the surface epithelium with or without thickened spinous layer. The hallmark histological finding is epithelial hyperplasia and surface hyperkeratosis. If epithelial dysplasia is present, it ranges from mild to severe. These are the histologic pictures of hyperkeratosis, mild, moderate, and severe dysplasia. Oral submucous fibrosis is characterized by submucosal deposition of dense and hypovascular collagenous connective tissue with variable number of chronic inflammatory cells. Epithelial cells, the changes include subepithelial vesicles in early lesions and hyperkeratosis with marked epithelial atrophy in older lesions. In lichen planus, the thickness of spinous layer can vary. The retiridges may be absent or hyperplastic, but they classically have pointed sawtooth shape. There is destruction of the basal layer of epithelium. It is accompanied by an intense band-like infiltrate, predominantly T lymphocytes immediately to epithelium, and the presence of Swot or hyaline bodies are a characteristic features, that is degenerated keratinocytes. This is the histologic picture showing the Swot bodies. This is the melanin, the picture of lichen planus. Hyperkeratosis and sawtooth retiridges are visible in this slide. Migration of lymphocytes into lower epithelium with interface regeneration of basal cell layer. Candidiasis, there is staining the smear with PAS. As you all know, it is para-amino acid shift. Carbohydrates in fungal cell walls and organisms easily identified by the bright magenta color. 10 to 20% of KOH or potassium hydroxide is used to rapidly evaluate specimen. This was a news when we were dealing with this mucormycosis cases also. During surgery, we sent specimens to be stained by the KOH. Toluidine blue staining is another method of vital staining. It selectively stains acidic tissue components, has affinity for nucleic acids. Vital staining is, as you know, the staining of living cells. There is rapid and non-invasive surveillance, and basically we can screen malignant and potentially malignant disorders. The method is to rinse the mouth for 20 minutes with a antiseptic solution. Use 1% acetic acid, which removes the ropey saliva. 1% toluidine blue application for 20 seconds. Rinsing with 1% acetic acid. Washing with water. There is a dark blue appearance which is positive, and the light blue is the doubtful appearance, and if there is no color, it is negative. So well scope is a visually enhanced lesion scope. The sensitivity is 98% and specificity is 96 to 100%. This is used in the early detection of oral cancer and pre-cancer. The blue light is used in the 400 to 460 nanometer wavelength. This is a non-invasive method. The dark areas signify abnormal mucosa, whereas the green autofluorescence will signify normal mucosa. This is the well scope. This is the naked eye vision, whereas this is the oral cancer, which is detected by the well scope. A very useful tool indeed. Thank you very much.
Thank you so much, sir. Indeed, it was a very informative lecture. Potentially malignant lesions is indeed a very big spectrum of consisting of many lesions, which are difficult to diagnose, differentiate, and obviously difficult to treat as well. But you've given a very beautiful summary of each of the lesions. How do you diagnose them? And we move forward. Now, I would like to invite the chairperson for remarks on this lecture. Dr. Paresh?
Thank you. Yeah, thank you so much for inviting me for being a chairperson here. And I'm privileged to be chairing this session for one of our colleagues, Dr. Rajshri Banerjee. We are both batchmates since the BDS and MDS period, and our parent institute of Dr. R. Ahmed Dental College, Calcutta. Thank you, Rajshri, for an excellent presentation and an overview on regarding the oral potentially malignant disorders that we normally face as pre-cancers, we call them. And what a impression you have created here, that these lesions can be diagnosed before the cancer comes in, and there are the staining part and the veloscope. These are adjuncts which can be used. But I think the gold standard remains the light as well as your fingers to diagnose them. And there is nothing better than the oral visual palpation technique of diagnosing them, and the gold standard remains as the biopsy. So an excellent presentation, Rajshri. There are some questions there. Can I take them, or will you be taking them up?
So we'll take it towards the end in the open discussion session.
Can I make a comment with the chairperson's permission?
Right, tell me.
Yeah, hi, and great talk, Dr. Rajshri. Just a couple of points. I'm a head and neck surgeon. Regarding histopathology being the gold standard, I completely echo your thoughts. We all should be proud that the only randomized oral cancer screening trial has come from our country with more than 1 lakh individuals, which showed that visual examination only in high-risk individuals is the only method to reliably diagnose cancer. As far as well scope and the other light aids are concerned, I endorse your view that histopathology is the gold standard, but by no means can the light-based oral screening aids be considered the gold standard. Certain studies show the sensitivity of well scope as low as 50%, along with the studies that the speaker mentioned. So just a couple of points, especially for the trainee and the young practicing surgeons.
Yes, you are totally right. So there is no doubt about it that veloscope and all only have a very less amount of sensitivity when we talk of diagnosis, and the oral examination or with the visual light remains the #1 technique for screening, and the histopathology remains the gold standard for whatever diagnosis of OPMDs or cancer is concerned. Thank you so much.
Thank you, sir. We would now move on to the scientific session 4th for today's day. And the chairperson, as you've just met, Dr. Shamit Chopra. He is the attending and chair, Department of Head and Neck Surgery, Patel Hospital, Jalandhar. He is also a member of the Board of Directors, Patel Hospital. He is also a member of the Executive Committee of the FHNO, the Foundation for Head and Neck Oncology. He is the member of the National Fellowship Task Force, FHNO, the Association of Oral and Maxillofacial Surgeon. He'll be chairing this session. And as for the speaker, he is Dr. Abhishek Mahajan. He's a consultant in the UK. He's done his fellowship in cancer imaging from London, and he's a consultant radiologist in Clatterbridge Cancer Center, NHS Foundation Trust. The session that he'll be speaking on is NIRADS, or Neck Imaging Reporting and Acquired Data System. Over to you, Dr. Abhishek.
Thank you, Kathy. And at the outset, I would like to thank Dr. Pawan, Dr. Reena, and Shruti for organizing this and giving me this opportunity. I think the topic was NIRADS and AI. I think I'll start with NIRADS first. So NIRADS, it stands for Neck Imaging Reporting and Database System, which is now the means to report imaging in the head neck cancers, and one should apply in the post-treatment setting as soon as possible to standardize your reporting in the post-treatment setting. So post-treatment surveillance has always been a challenge for both the clinician and the radiologist, and then there has been significant discrepancies in terms of which is the right modality to use. It's very subjective in terms of reporting, and also there has been variable data in terms of how the imaging reporting has been done, the accuracy, diagnostic accuracies, and the outcomes. So various guidelines exist for post-treatment guideline surveillance. NCCN says that if there are no symptoms, the first imaging can be done post 6 months of the therapy. However, with the implementation of NIRADS from 2016, there has been significant standardization and the communication between the radiologist and the treating physician as to how the reporting is done and what is the challenges which are faced during the reporting and what should be the clinical implication of this NIRADS reporting database system. So the surveillance algorithm which we follow here a bit different from now what I used to follow back home. We do a PET and CT at 6 months, and if it is negative, then we follow up with CT neck and chest, and if it's negative, then CT neck again, and then we do a routine follow-up at 12 months, that's 1 year. However, NCCN says that if you are using a tool as a CT or a PET CT at the end of treatment, it should be done at 3 to 4 months. But if CTRT is used as a curative intent, then imaging at 4 to 6 weeks would be an ideal imaging, 4 to 8 weeks. But I, in my practice, recommend using at 12 weeks because you can get a better response, incomplete response. If you are clinically suspecting, then at 4 to 8 weeks is the right time to use PET-CT. In patients who are at high risk of lung cancer or synchronous malignancies of the upper GI tract, have a history of smoking, they should also undergo a chest screening at the time of the CT scan, and it does not add much cost to the routine screening protocol, and it adds benefit into picking the second malignancy early. So previously the criteria was there to do imaging in the head neck post-treatment setting. However, this was very subjective and it was based on the PET modality alone, and they used to use IJV and the liver uptake as a standard tool. So if you had IJV uptake, the uptake in the lesion less than IJV, it was a complete response. If it was between IJV and liver, it was metabolic response. But any focal uptake beyond liver or any focal intense uptake was suggestive of a residual tumor. So this was quite subjective and it was only PET-based. What NIRADS did is, NIRADS has included the various lexicon measures where there is definition for non-mass, mass-like enhancement and mucosal abnormality. Mucosal abnormality is the one which you commonly see in your practice, and it is mostly related to radiotherapy, which leads to mucoid density, diffuse renal enhancement or mucosal enhancement. And nodes are also categorized separately. So there is a separate lexicon for nodes in the primary lesion. The nodes, if there is no residual disease, it will not show any morphological or functional uptake in the disease area. And if there is a growing node, it is taken with a pinch of salt. So NIRADS category range from 0 to 4. The 0 is inconclusive, where you need an additional tool. Let's say you've done an MR or CT at the baseline, and then you are not very sure of what is happening in the local site or the nodal site, then you would call it as NIRADS category 0. But the normal categories which are used into the lexicon are 1 to 4, which is category 1 stating no evidence of tumor. Category 2 is ill-defined, mild, moderate FDG uptake, which is a treatment-related change and it's clinically evaluated and labeled as category 2. It is further divided into 2A and 2B, which we'll see in the subsequent slides. Category 3 is a very high index of suspicion where you need to do a biopsy and inform the clinician that this lesion needs a biopsy. Category 4 is definitive recurrence, which is pathological or clinical proven recurrence, and it is or a radiographic progression. And these patients are either managed palliative or with or new treatment modalities such as immunotherapies and so on. So let's look at when you call a category as NIRADS 1, you do a routine follow-up at 6 months, which is routine recommendation as per your guidelines. The NIRADS 2, if it is a mucosal site uptake, which can be seen on direct inspection, then you can do a direct inspection, which is called as NIRADS category 2A. If it is a deep-seated lesion in the high ITF or in the deep submucosal region where you cannot do a clinical examination, it's called as NIRADS category 2B, where you need to do a short interval follow-up with PET. And if there is an uptake, then you would take it as NIRADS category 3 and do a biopsy. So NIRADS category 3 is a strong indicator that there is a recurrence, and this should be biopsied in all cases. NIRADS category is a clinical care of recurrence. So let's look at some cases. The first case is the 35-year-old male who was case of a base of tongue squamous CA T1N2C, underwent radical chemoradiotherapy. You can see the primary disease over here. And there was a node which was treated with radical CTRT. The patient had a 3 months, 12 weeks post-surveillance PET CCT. No uptake is seen, mild mucosal thickening, and this is no abnormal soft tissue, no abnormal FDG uptake. This kind of findings, which are no abnormal soft tissue, no abnormal distortion, mucoid-like intensity in the treated region, or diffuse linear enhancement, these are radiation related. They are called as NIRADS category 1. The NIRADS category is separately labeled for primary in the node, and a routine surveillance is advised. The chances of the negative predictive value for NIRADS category 1 is 94%. The next case is a 43-year-old male diagnosed with base of tongue malignancy. Again, he was a T4A cancer. There was a large disease over here, which was FDG avid, and there was a avid node as well. The surveillance scan at 3 months showed mild mucoid and change in the primary site with focal uptake. This was a discordant finding. So NIRADS category 2 are usually discordant finding. Either there is a FDG uptake with no mucosal abnormality or mucosal abnormality without FDG uptake. So in NIRADS category 2, you see that there is no, in this particular case, no abnormal soft tissue but moderate FDG uptake. This is a NIRADS category 2 because the clinician can do a direct visual examination, and based on the changes in the mucosa, it can be labeled for a close follow-up or a biopsy. So NIRADS category 2 are focal superficial enhancements or focal uptake which are discordant with each other. And the NIRADS category 2, as I said, they are further divided into 2 subcategories. If it is superficial, the patient can undergo a direct inspection. If it is deep, it can require a short interval PET uptake, which is done at PET CT, which is done at 3 months. So remember that discordant finding should always be labeled as NIRADS category 2. The next case is a 28-year-old female, which she was a diagnosed case of maxillary carcinoma of the sinus and underwent resection and chemoradiotherapy. This is the primary tumor, and after resection on follow-up, there was a focal enhancing soft tissue with the bony changes, and it was showing intense FDG uptake, which was quite similar to the brain parenchyma adjacent to it. This patient underwent, so there was a concordant finding with the soft tissue, which was showing intense uptake. And this patient underwent a biopsy, and the biopsy turned out to be a recurrent tumor. And in the NIRADS category 3, you have a concordant finding with the abnormal enhancing soft tissue on the morphological imaging and intense uptake on the PET imaging. So any NIRADS category 3, a recommendation is to do a biopsy, and the positive predictive value for this is approximately 60%. The next case is a 47-year-old female. She was a case of CA tongue, T2N2, underwent surgery for the primary and neck dissection at 3 months outside the hospital, and she came to follow up at Tata Memorial Hospital. She was 3 months post-surgery presented to our hospital for further management. So at the 3 months post-therapy, the patient came to the hospital, a baseline imaging was performed to decide on the further management, and no abnormal soft tissue was reported on this. The patient underwent another imaging at 9 months post-therapy, which was done with PET CCT, and there was an abnormal nodal soft tissue which was showing intense uptake, which on retrospect was close to the vessel and was marked as abnormal in the previous 3 month scan. This patient underwent a biopsy, and this turned out to be a recurrent tumor, and this was then salvage neck surgery was performed, and this was positive for recurrence. The NIRADS category 4, as seen in this particular case of laryngeal cancer, which was a post-op laryngectomy case where there was a large soft tissue at the stromal site with ulcerating lesion. It was seen in the clinic and was labeled as a recurrence. The PET scan was performed to see whether there was other sites of metastasis. And NIRADS category 3 and 3 or 4 can be performed backwards. These patients usually don't need biopsy, but to label them as palliative, you need to do evidence-based management to categorize them as recurrences if they are smaller recurrences. So NIRADS category 4 is pathologically proven recurrence, or there is definitive clinical progression or definitive recurrence on the single site of the surgery. We have our data from where we had done a retrospective study on a cohort of 800 patients, and we found that a significant correlation with NIRADS reporting in the category 1, which were 100% accuracy, 100% negative and positive predictive value, which dropped down to 70% and close to 70% of the positive predictive value in the NIRADS category 3, with very good results in the NIRADS category 4 as well. The results were better in terms of the nodal cohort, and if you see the NIRADS category 2 and 3 were performing very well. So if you are labeling node in NIRAD category 2 and 3, this was CT based data, and remember that CT always is a subjective modality, but did perform very well in our cohort. So NIRADS is based on the site of the disease. So primary, if you have NIRADS category 3, you do a surveillance. If it's NIRADS category 2, you do a direct inspection, and it's a 3, then you do a biopsy. And if it's 4, you don't need to do a biopsy. You can directly manage the patient accordingly. Similar to the for the nodal site, you have NIRADS category 1, which is routine surveillance. If it is a superficial node, you can do a short interval follow-up or a biopsy of the patient if it's strongly indicated in NIRADS category 3. And if it is definitive nodal increase with the serial imaging or on the biopsy proven, then it's managed accordingly. So not all cases are so simple. Sometimes you find tricky cases, and seen in this particular case, this was a case of adenocarcinoma of the sinonasal cavity, which underwent surgery. And post-surgery, there was no residual disease. It's a flap. You see no uptake in this area. Patient underwent the and post-follow-up, you see that there is significant moth-eaten appearance of the bones in the skull base. This patient had admixture of post-treatment changes with enhancing soft tissue, which was suggestive of osteoradial necrosis with recurrent tumor. So sometimes you find challenging cases where the patient is actually in deep morbid state, and you have to take a decision. Not all cases should be labeled as post-treatment. Sometimes you see admixture of the disease as well. So the take-home message from my NIRADS is practical imaging surveillance template, which is used to guide appropriate imaging interpretation, follow-up, and next clinical management steps. And it helps standardization to link with the management recommendations, correlation with patient outcomes that has potential to validate performance and highlight the radiologist value to the patient care. I'll show a few slides on AI, machine learning, and neural network and deep learning. It's a very new, innovative tool which is still upcoming in the era of head neck cancers, and a lot of work is done in preclinical imaging and also in the assessment of the tissue slides. But a lot is pending in terms of the radiology AI. So AI is actually a computer programmed which is made to think and behave like a human being. But machine learning is a niche area of AI where you tell the machine to do data processing as to being not explicitly told what to do. And when you do any machine learning algorithm, you use something called as neural networks. These are the backbone of any machine learning algorithms. They are similar to human neurons, and deep learning is the algorithm which you use to do a machine learning. So neural networks are basically like a neuron. You give an input signal. There are hidden layers which is similar to the brain processing unit which process these signals and give an output. So there's an input signal. There is activation of threshold. There's input from each dendrite which is summated and then generates an output signal. So how a human brain thinks looking at an apple, it processes the image into multiple subsets being the color, the shape, and the texture, and it processes the fruit as an apple. Similarly, an apple is presented to a neural network which is broken down into multiple pixels, which these pixels are read as color, shape, texture, and other features, and they are read by the computer algorithm as an apple. So machine learning is of 3 types. What commonly used in medicine is the supervised and the unsupervised learning. The reinforced is the one which is used in the AI, in the trafficking, which is the motor trafficking. So what is supervised learning? In the supervised learning, you have an input data, a training, and an output data. The data is labeled. Any kind of data which is labeled, that means you tell whether it is a benign or malignant disease a priori. That kind of labeled data is called as a supervised learning. So let's look at an example. The data is split into 2 parts, training and the test data set. The training model is labeled data set from where you do the deep learning algorithms. Once the deep learning algorithms are done, they are evaluated on the test data set, and this is used for clinical evaluation. In an unsupervised learning, you do not label a data set. The data set is automatically divided into groups by the deep learning algorithms into 2 various subgroups. And this is much more better way because it removes the bias. But however, if the data is too heterogeneous, that may lead to underperformance of the algorithms. So let's look at these 4 set of coins. They are different in color. This is being processed by the algorithm, and they have been divided into various groups, something similar to stages of the cancer. The computer understands there is a red color, there is a gray color, and there is a blue and a yellow color. This kind of learning is unsupervised machine learning. So in radiology, we use a radiomics cycle to do a deep learning algorithm. You do image acquisition, you do segmentation of the imaging, then you do feature extraction and do analysis. I'll give an example from what is published by our group. In the lung, you do acquire the images, you do segmentation of the images, you do extraction of the features, and then you do the selection and analysis with outcomes. So artificial intelligence used by any kind of machine learning algorithm can be applied to diagnosis, can be applied to treatment, and can be applied to prognosis. We've had several publications in this era by my group where we've used AI in lung, brain, and other areas to even predict gene mutations and do segmentation and outcome analysis. And I'll end my AI talk with that, with the SWOT analysis, that the strengths in India for AI is availability of big data, emerging talent pool, and availability of qualified professionals. However, the weakness is that there's inadequate source allocation. There's very little awareness and acceptability and standardization of data set. Standardization of data set is a very important area where we need to concentrate before applying any AI tool. The opportunities in India are the public and the private partnerships, the national and international collaborations. The threats, which I do not feel any threat it is, there's no job redundancy. However, people do talk about job redundancy. The biggest threats in this particular era is the legal and the ethical issues. Many of us are using the patient-related data without taking any approvals from the institutional boards, and data privacy issues are one which are going to be the challenging issues in the AI applications. So with that, I thank you for your kind hearing, and any questions I'll be happy to take. Over to you, Shamit.
Great talk, Abhishek. I think you can see the comments in the chat box. I think everyone is united in appreciating the conciseness, still giving the information that you're able to give. Before we turn on to questions, I will ask you something about NIRADS. You work at an Apex Cancer Center and you continue to work at another Apex Cancer Center. How challenging is the incorporation in a multidisciplinary setting? We all know that we went through that phase in TIRADS and Bethesda and everything, and now everyone has standardized approach that. Is NIRADS particularly applicable in the neck, where you showed better data, especially for NIRADS 2 and 3? More accuracy, acceptability, and how's your experience been? Just a minute of that, please.
So before NIRADS, we used to randomly report cases. There was a lot of heterogeneity in reporting with inter and inter-reader. Sometimes you might get your own report and you read it again, and you're not actually going to categorize into one category. So NIRADS give a level of confidence to a radiologist to put in a category. With this category, you are sending across a message to the clinical oncologist who's going to treat this patient. So with these standard linked recommendations, you can actually manage the patient better. It's a very simple tool, not much of things applicable. We have our NIRADS template on the website, which will be coming as a publication soon. So you can use this template, which is modified to Indian subcontinent, where CT and MR are the primarily used tools. And we have also made similar templates for per primum cases also. So I think synoptic reporting and any kind of linked data recommendation guidelines such as BIRADS, TIRADS, and others, they improve the diagnostic accuracy and also the outcomes. Randomly reporting cases can be challenging, I feel.
Totally agree. And I'm sure after this talk, a lot of us will go back to our radiologists and nuclear medicine physicians asking them to adopt this. Have you found it more applicable in MR versus PET? And is there a particular timeline where you have found the NIRADS to be more representative compared to a different one? I know you mentioned the 6-month timeline. All of us follow the 3 months. Just your thoughts on that.
So the basic challenge which we face in our hospital is because you are very sure of the treatment protocols in your hospital, it's easy to apply there. But if the patient is managed outside and the patient comes to you and you are not very sure of the kind of surgery and treatment the patient has got, it becomes challenging. So in our hospital, we don't have a very routine protocol of doing PET CT in all the patients. So they used to be managed, imaged accordingly. Like if there was a larynx cancer treated with CT-RT, we would do a PET CT, then followed up with CT. And if it was a tongue cancer, we would do a MRI. So our data on NIRADS was based on the routine protocols which are used in Indian subsetting. PET is not a strong recommendation, but the challenge is only if you sit with your clinicians on the MDTs, you can actually get to know what the clinician is seeing and what you are actually seeing on the images. I think it needs a bit of a training by the MDT meetings, and once that is done, the radiologist will be very confident in applying this.
Again, great speaking and well chosen topic by the organizers. That's it from me, and over to Khyati and Shruti and Pawan.
Thank you, Shamit. Thank you, everyone.
Thank you, Dr. Shamit. Thank you, Dr. Abhishek. Definitely, you've given a great idea about NIRADs, and now everybody knows about it, and I hope we can soon incorporate it in our system as well. Dr. Pawan, let's do something about this as well. Thank you, and I give it over to Shruti.
Thank you so much, Dr. Khyati, and thank you so much, Abhishek ji and Samit sir for a wonderful summation on NIRAD. I think it's the beautiful, all sessions were absolutely fantastic. We come to the end of technical sessions. And now we move towards a prolific panel discussion, which is moderated by Dr. Narayan Subramaniam. Sir is currently consultant and HOD, Head and Neck Surgical Oncology at Shankara Cancer Hospital, Bangalore. As a surgeon, he has experience in all facets of head and neck oncology and skull-based surgery. He performs reconstructive microsurgery with expertise in dental implant-driven jaw reconstruction and facial nerve reanimation. Currently pursuing a PhD in oral cancer immunology from Manipal Academy. Has published over 110 peer-reviewed articles and book chapters on head and neck oncosurgery. Without wasting much time, I would like to invite Sir to take the panel discussion ahead.
Thank you very much for the introduction. It's been a fantastic session so far. So we'll move right ahead. We're a little short on time. So I would like to introduce our chairpersons for the panel discussion. So our panel discussion is on diagnosis and workup of oral lesions and radiological interpretation. Our first chairperson is Dr. Shalu Rai, who is the principal of IDST Modi Nagar. She's responsible for curriculum development and she's a reviewer for various national and international journals. She has 64 publications at a national and international level and she's authored 6 books. Welcome, ma'am. Our second chairperson is Dr. Usha Agarwal, who is scientist and director at the ICMR National Institute of Pathology in Delhi. She's done her MD pathology and her PhD. She's an academician and an oncopathologist. Her areas of interest are breast and bladder cancer, biobanking, digital image analysis, and AI in pathology. So welcome, madam. Thanks for having you. Our panelists today, we've got a very diverse panel, a very skilled panel. We have Dr. Amit Janu, who is assistant professor, diagnostic and IR at DMH. We've got Dr. Prashant Vanzar, who is a consultant cancer surgeon at Sterling Hospital. We have Dr. Neha Mittal, who is a professor of pathology at TMC Mumbai. We have Dr. Aditya Joshipura, who is a consultant surgical oncology at HCD Cancer Hospital in Sola, Ahmedabad. We have Dr. Swagnik Chakrabarti, who is director of surgical oncology at Chandan Super Specialty Hospital in Lucknow. We have Dr. Manoj Tayal, who is director and clinical admin, radiation oncology at Max Super Specialty Hospital, Pattangarh, and Dr. Ankur Mittal, who is the HOD of oral and maxillofacial surgery at DJ Dental College. So welcome everybody. We're just going to jump into the panel. So I'll just share my screen. Okay, is my screen visible?
Yes, it's visible, sir.
Okay, so our panel is on diagnosis and workup of oral lesions. So the first scenario is a leukoplakia. So this is a 47-year-old female with a history of a diffuse whitish patch on the left lateral surface of the tongue. As is the definition of leukoplakia, it cannot be rubbed off. So the surface area of the lesion has been increasing over the last 3 months or so. She's not had any previous patches, biopsies, or interventions. Her only symptom is that she noticed it and maybe some vague feeling of irritation. So no pain, no bleeding, no loosening teeth, no symptoms or signs of invasive oral cancer. So this is a scenario we see very often. So we'll start off with the questions to the panel. So the first question is for Dr. Prashant Vanzar. So what history would you ask the patient that guides your management?
Am I audible?
Yes.
Yes. So, good afternoon, everyone. So, I will ask in the history of the patient for an addiction, specifically the betel nut or.
Oh.
So I will ask for the addiction for this to this lady. Any history of tobacco chewing or in any form or smoking product, and I will examine the patient for any sharp or such another lesions or any treatment in the past. It's already have mentioned that no biopsy or an intervention previously done for this patient. So clinical examination and history will suffer for me.
Okay, perfect. Point very well taken. So you have to have a thorough history and clinical examination that helps you establish a diagnosis. So our next question is for Dr. Swagnik. So what are the management options available in this patient? So let's say we do a biopsy and it comes as mild dysplasia. So what are the management options that you would make available to this patient?
So, hello, madam. Am I audible?
Yep, audible.
Yeah. Yeah. Hello.
Yes.
Yeah. So, this is a diffuse leukoplakia, which is on biopsy shows mild dysplasia, which looks homogeneous to me. So, first thing, the patient has to quit the habits. Patient quits habits, and then we follow this patient up. Being a homogeneous leukoplakia, and it's extensive. So resection with clear margins may be difficult. So my call will be to observe it for 3 to 4 weeks and see how it behaves. If it stays back or it does not regress, if it regresses, we'll observe. If it stays or increases, or there is some symptom that points towards malignancy, we go for a re-biopsy of the thing.
Okay, so I think that point is very well made. You have to see that you get rid of the irritants. If there's a chronic irritation or there's a habit, you get rid of it. It is a lot more challenging when there's extensive involvement. As surgeons, our hands itch a little bit. We want to excise everything that looks fishy, but it may not be a good option when you have a large diffuse area. So go with your clinical judgment. If it's homogeneous, if it can be observed, it's worth observing. So my next question is for Dr. Neha Mittal. So what is your advice to whoever is performing a biopsy of this lesion? So you have a large surface area. How do you make sure that you get a representative area?
Thank you for that question, and thank you to the organizers for making me a part of this panel. And I think my job has been made much simpler by that wonderful talk by Dr. Banerjee. And so a biopsy of a leukoplakic lesion entails, number one, that to the clinician who's performing the biopsy, I would want them to record in the form that whether type of leukoplakic lesion, is it a homogeneous lesion, is it a speckled or a nodular lesion? So type of leukoplakic lesion, to say that, the extent of the lesion, the site, of course, and whether or not there are areas which are suspicious for malignancy, and specifically pertaining to this case in which you're saying that it is a large lesion. So hence, there may be a requirement, or this may be a case for multiple biopsies or mapping biopsies, and that may be done in such a case. And in which situation it is important that the clinician clearly indicates which are the areas which are suspicious for malignancy or dysplasia. We all know that speckled and nodular type of leukoplakic lesions have much higher chances of dysplasia and harboring a malignancy compared to the homogeneous type of leukoplakic lesions. Another important point is that if possible, a part of the adjacent normal should be included in the biopsy, because comparison with normal helps a lot in identifying these early and subtle lesions which may just show mild architectural atypias and may not so much show the cytological atypias. Also, a punch biopsy is much more preferable than any type of cytological methodologies, because a punch biopsy specimen gives us, at least a punch biopsy specimen gives us the potential to do certain newer and certain immunohistochemical or certain markers, and to look at architecture much better as compared to cytological methodology.
Perfect. I think two very important points. One, that establishing the diagnosis is teamwork. So you need the clinical suspicion, you need the pathologist's expertise as well. And also that when you have a lesion like this and you're going to be following it up, there's a chance that you may end up biopsying multiple places down the line. So you may not excise it. So you may have different areas that develop dysplastic changes or malignancy. So mapping it is very important. If you can take photos, please have a way of documenting that. So the next question is for anybody who wants to take it actually on the panel. So what is the role of chemo prevention in leukoplakia? Anybody wants to volunteer to answer that?
There is no proven role of chemo prevention leukoplegia. There has been studies that have shown there is some temporary benefit of vitamin D, but vitamin D systemic application has its own toxicities, and the lesion reverts back after removing after stopping the treatment. So no proven role of chemo prevention, as of today in the treatment of leukoplakia.
True. I think we are lacking a bit.
I want to add something.
Please.
Is there any role of local application of retinoic acid in there?
Yes, retinoic acid. Got it. So I think I agree with that completely. We had some data that was from several decades ago that showed that it may be beneficial. Chemoprevention is basically medication taken that prevents either the development of new patches or say the progression of the existing patches. But unfortunately, the effect is not durable. So once the patient stops taking it, the effect wears off, and also they have their own toxicity. So a lot of the time we prescribe patients a bunch of placebos, whether it's vitamin A or anything else. But even if we perform the patient placebos, we need to make sure that there are no side effects. So that's very, very important. Unfortunately, we don't have a very good medical management of this. So the next question is, if you have extensive leukoplakia involving the entire oral cavity, so the patient opens the mouth and all you can see is leukoplakia all over the hard palate, all over the buccal mucosa, alveola, and the tongue, how are you going to manage that? Anybody? Dr. Prashant, you want to take that?
Yes, with the permission.
Yes,
so
please.
Being practicing in Gujarat, we oftenly used to see such type of patients with extensive leukoplakia occupying major part of the oral mucosa that it's not amenable for surgical resection, of course. So as Dr. Neha Mittal said rightly, so there is no lesion which is absolutely homogeneous. So there are some particular part in that lesion we can of course diagnose by doing punch biopsy or incisional biopsy, and if they are malignant, then we used to treat that. Otherwise, if it is completely homogeneous, then I would like to keep under placebo treatment and do some laser sort of treatment to the aggressive looking lesions. But of course, not an aggressive surgical resection for removal of entire tumor. So it will vary patient to patient depending upon the lesion characteristic, and I will concentrate my vision to observe the abnormal looking lesions. Of course, the entire mucosa will not be, they will be having different characteristics. So I will keep the patient under observation and I will follow up the patient.
Great. Excellent point. Very well taken. You may have to combine radical interventions along with conservative ones. So if you have a focus of invasive malignancy, you resect that with margins, and you do a superficial laser kind of excision for the other areas, because you have to avoid morbidity, number one. And secondly, also, because there's no guarantee that after resecting that area, you won't have a leukoplakia popping up in another area. It's more, we think of it more of a systemic problem in the upper air digestive tract. So another question, so what is proliferative verrucous leukoplakia? So amongst all the leukoplakias, we know PVL as clinicians are the ones that we have to be worried about. Dr. Aditya, you want to take this question?
Yeah, sure. First of all, thanks for the opportunity, and thank you, Narayana sir, for this question. Yeah, so proliferative verrucous leukoplakia is an entity that is a bit distressing for us as clinicians, because it involves a broad proliferative part of verrucous leukoplakia that is extremely resistant to conventional treatment. It involves multiple confluent areas of patchy leukoplakia, out of which some of them may be proliferative and verrucous. Conventionally, it has been shown that they have a high rate of local failure, resistance to treatments, and of course a very high rate of malignant transformation later in life. So they represent a clinical and a management challenge for us.
Very good point. So we always have to keep this in the back of the mind, especially when we see elderly women with extensive lesions. A third of them can have tobacco use. Keep this entity in mind. You do not want to keep this on observation. You want to manage it radically. So the next case scenario. Yes, please.
Regarding the proliferative verrucous leukoplakia. Yeah. So it is not only a lesion which is leukoplakic lesion, so to say oral pre-malignant lesions, or potentially pre-malignant lesions are not only a challenge for clinicians, they are also a challenge for pathologists. With if you see any kind of pathology related involving oral pre-malignant lesions, there will be a lot of heterogeneity in the diagnosis, and the heterogeneity is more towards lesions which have low amount of dysplasia. So that is why important, as I said, importance of clinically mentioning the site of biopsy, the type of lesion that we are seeing. And in that regard, proliferative lipoplakia has a special significance because, this has a very characteristic clinical appearance of this verruciform appearance of the leukoplakic whitish lesion. And on biopsy also, this is, this, as the name suggests, it is proliferative and verrucous, but may not be seen, this kind of a change may not be seen in all cases. And on histopathology, it shows a spectrum of morphological changes from early to late, in which the proliferation may be mild to severe and the dysplasia also may be from mild to severe. Then chances of malignancy are up to 50%, and a non-smoker population is the kind of population that you see these lesions are commonly. Also, this as a clinical history, these lesions may be indolent for some time and then suddenly show a very aggressive malignant transformation. So that is also known for as a clinical behavior in these cases. Very recently, as I said, there was heterogeneity in labeling these lesions. So very recently, we've had a consensus classification for identification of verrucous lipoplakia, and a group pathologists has gotten together, and these terminologies will now be included in the new WHO book on head and neck cancers with oral lesions. So, now there is a standard pathology reporting, and I would urge all the clinicians that, encourage your pathologists to have a standardized reporting for all kinds of oral, potentially and pre-malignant lesions, mentioning of the degree of this, degree of architectural changes, degree of cytological changes, categorizing the dysplasia at least in a binary fashion, low or high, and of course mentioning the special categories of leukoplakia, which includes proliferative verrucous leukoplakia.
Excellent point. So I think for good outcomes, it's our responsibility as clinicians to give the maximum information available to the pathologist and the radiologist and everybody else who is helping us make clinical decisions in order to get accurate information out of them. So we'll move on to the second scenario, which is tongue cancer. So this is a 29-year-old male who had an ulcerative lesion on the left lateral tongue for around 5 months. You can see tobacco-stained teeth and poor oral hygiene. He has occasional bleeding, pain, and earache. On clinical examinations, it's a 5 by 3 centimeter exophytic and fungating lesion with a partly whitish and reddish surface. There are also enlarged left level 1B and 2A lymph nodes, the largest 2 by 2 centimeter in size. So my first question is to Dr. Amit, our radiologist on the panel. So what do you keep in mind when we so we had a great discussion, of course, on imaging of tongue cancer. So what would you like to cover when you discuss MR imaging of tongue cancers? What are the salient features that you think you'd like to discuss with all of us?
Okay, thank you, Narayana. So basically, we will see the thickness of the tumor that is involving, the size of the tumor also we are taking into account, and then the local spread. So whether it is extending across the midline, going to the posterior third of the tongue, having a sub floor of the mouth involvement reaching up to the hyoid, and then spatial affinity when it is touching the neurovascular bundle, whether there is any perineural spread is there or not, or it is encasing the lingual neurovascular bundle, and then the lymphatic spread that is occurring in most of these lesions. So the one is the nodal burden and the extent of the nodal disease, whether it is encasing the vessels, whether it is an IGV or the carotid or some other structure which is potentially making it is inoperable. So these are the things actually we want to see when we are reading about a head and neck scan, especially the oral tongue.
Perfect. And the second part of that question is, what are some of the newer parameters being considered? So we've heard of ADC and other things. So what would your take-home message be as a radiologist? What do you think we should look forward to in the radiology of oral cancer?
Yeah, so definitely ADC is basically when we are taking about the cellularity of the tumor, and it is an indirect parameter when we want to assess the cellularity of the disease, and it will help in formulating whether this particular node or this particular area is going to be metastatic or not. Sometimes we are struggling whether there is an edema or there is an extent of the disease, and especially some newer parameters like perfusion, diffusion, and other some sequences which will help you in formulating the extent of the disease as well as the metastatic burden.
Understood. So hopefully we'll see more research in these areas and they'll become more commonplace in clinical practice. So So the next question is to Dr. Aditya. So what are the factors that determine resectability in a tongue cancer? So Dr. Amit summarized that up quite nicely, but for you, what are the key areas that you want to look at as a surgeon and help you in decision making?
So, firstly, I would absolutely want my radiologist and my reconstructive surgeon to be in sync with my anatomical resection before I go ahead and decide the resectability of the tumor. If I were to broadly look at the exact factor that I would look at as a surgeon in terms of removing the tumor, they would be, as I said, volume of the tongue involved, whether the lesion is crossing the midline or not, the neck nodal metastases that are there, the potential of distant metastasis in a tumor that is maybe crossing the midline or a locally advanced tongue tumor, the extent of extrinsic muscles involved or the intrinsic muscles involved, and as the paper on the compartmental resection of the tongue said, whether it is crossing compartments in terms of floor of the mouth, involvement of surrounding structure like the mandible or not. Perineural, again, I would try to pin my radiologist down as much as I can to tell me about perineural spread, because we have seen a lot of cases failing proximally in terms of involvement of the perineural bundle away from the primary tumor. That is the anatomical part of the thing. The other thing that I would consider would be the physiological part, as in if the genioglossi of both sides are involved in the floor of mouth, then that would mean that the patient might require a long-term or a short-term tracheostomy. So that is something that I would have to discuss with my patient. Even though anatomically and technically resectable, that is something that is going to give the patient a lot of morbidity in the future. Base of the tongue involvement again may cause the need to do a partial laryngectomy in order to avoid aspirations, and also that is something that I would consider. And of course, the reconstructive need. If I have a very competent microvascular surgeon in my setup, I would be bolder in removing the volume of tongue that is necessary to achieve complete cure. If not, then that also may influence my factors. Again, all of these factors are about resectability, but they also have to be considered in terms of whether that will give a quality of life to the patient or not. So the last factor that I would say is the patient's willingness to undergo morbidity, especially in locally advanced tongue cancers.
Point very well taken. So the next question is for Dr. Manoj Dayal, a radiation oncologist. So in what oral cancers would you consider radical radiotherapy in place of surgery?
Yeah, thank you organizers for making this efforts and making this in place of a good success. So radical radiation for oral cancer tumors. So it's very difficult call to take, because if it is a small tumor, say a T1 tumor, and there is no node involvement, so I will definitely offer radical radiation in these patients. Otherwise, my take for these patients will be to go for surgery followed by radiation.
Understood. So very small selected early cancers,
especially
therapy.
Yeah.
Perfect.
So the case you have presented, I'll definitely ask for surgery and followed by adjuvant radiation.
Understood. So we have to understand the advantages and disadvantages of every modality of treatment in cancer, and we have to work together to make sure that the patient gets the best possible treatment. Thank you, sir. So my next, yes, please. Sorry. So you had something to add? Sorry, did I cut you off? Your voice is breaking. Sorry. Could you repeat that last point? I think there's a network issue. So we'll go on to the next question if that's all right, and we'll come back to Dr. Manoj Dayal. So my next question is for Dr. Ankur Mittal. So in our country, we see a lot of chewing tobacco, we see a lot of pan, we see a lot of oral submucous fibrosis. So when you are seeing an oral cancer like this, but mouth opening is very poor. So if you have severe trismus, how does that make your management more challenging? So what is your approach?
Good evening, doctor. Can you hear me?
Yes, perfect.
Can you hear me?
Yes, perfect. We can hear you, sir.
Yeah. Yeah, good evening, doctor. There are a lot of treatment plans which is going on in this thing. Stage 1 therapy, we used to go for a physiotherapies and exercises for the patient. Physiotherapy is like mouth stretching exercises for patient if patient can do it. Otherwise, we used to go for mouth stretching exercises for the patients. Another thing which is most important is Christmas appliances we used to give to the patients, like scattered wooden spatulas what we give to in between the teeth so that muscles can stretch and open it. Another thing we can go for an Heaster's mouth gag and Ferguson's mouth gag, which we use it for mouth stretching or exercises. The next stage surgery which we use to go for is drug therapies like analgesics, anti-inflammatory drugs, and muscle relaxants, what we used to give to the patients. Newer studies we try sometimes botulinum toxins and pentofixylin drug for muscle relaxant type drugs. The third stage surgeries we used to go for release surgeries like coronectomy and temporal muscle release. And scar revisions, if we are treating a post surgical treatment, then there is a scar and there is a difficulty in mouth opening, we used to go for scar revisions. And the last thing what we can go for is control of infections.
Very well taken. So it's very important when oral cancer. Sorry, I think somebody is not on mute. So it's very important when we manage oral cancer. It's very important when we manage oral cancer to also think of the trismus that the patient has primarily or also will develop as a resultant of the treatment. So I think you summarized that well. If we have a patient like this with oral cancer, we may have to change our approach. We may have to do a mandibulotomy or a pull-through approach. So I think the next two questions were partially covered. So I'll go on to the next case. So scenario 3 is an unresectable oral cancer. So this is a 37-year-old male with an ulcer-proliferative lesion on the right cheek for around 9 months, which has recently become an oroantral fistula. So he has complete trismus, halitosis, pain, and bleeding. On examination, there is an extensive lesion involving the entire right side of the face with an oroantral fistula. Extensive skin involvement, including the neck skin. As you can see lower down, you can see the dilated veins on the surface of the neck and multiple hard fixed nodes in level 1 to 5. So my question to Dr. Amit is, how do you determine resectability in advanced oral cancer? And how do you differentiate between inflammation and tumor when you have extensive lesions like this?
So basically, what we see is that the disease is superiorly, it is going above the mandibular notch, where we call it as an high ITF involvement. Inferiorly, where it is going into the hyoid or below that, or it is involving the hyoid. And whether there is any involvement of the mandible, whether it is paramandibular soft tissue, erosions and destruction involving the floor of the mouth, and then the nodal disease, and whether it is behaving at the same, whether encasement of the vessels, and any perineural spread that is going higher up into the higher ITF or probably going into the cavernous sinus. So these are the factors which will help affect resectability. And then whether there is any involvement in the pterygopalatine region and involvement of the pterygopalatine fossa. So these are the some factors actually where we are looking after on the imaging, and then we will help our clinician where they cannot see the disease. Second thing about the edema versus the disease, it's a tough call sometimes, but most of the time we will overestimate the disease, because most of the time when the tumors are large, the edema is going to be high. And if the lesion is matching on all the sequences that we are having, it is going to be the part of the disease. But if it is not matching, like the stir is not matching with the pre-contrast T1, then the extra part that we are seeing it on the stir or is the edema, or seeing on the post-contrast enhancement is going to be the edema. So that's how we will try to differentiate based on the conventional imaging. We have some additional markers like perfusion and diffusion weighted imaging that also increase your level of confidence whether this area is particularly an edema or a part of the disease process. So this is how we will try to stratify the patient.
Understood. So the next question is for Dr. Swagnik. So how do you palliate an unresectable oral cancer? So this is a case, obviously we cannot operate, we can't get negative margins. So how do you want to palliate this patient?
Palliation can either be radiotherapy with chemotherapy, just chemotherapy, or best supportive care. For a patient who has a local disease which is unresectable and has a good general condition, good ECOG status, young patient, no skin fungation, palliative chemotherapy with radiotherapy is the best option for palliation. However, in cases where the performance status is poorer and radiotherapy cannot be given because either of skin grossly involvement, as in this case, or there is significant distant metastasis, palliative chemo remains a better choice. Owing to the fact that palliative chemotherapy plus radiotherapy is more toxic than palliative chemotherapy alone, chemotherapy can either be in the injectable form or in the tablet form as oral metronomic chemotherapy, depending on the ECOG status of the patient. And the last point is best supportive care, especially for a patient like this patient. Nothing can be achieved with the chemotherapy or radiotherapy, or if the patient is elderly, poor functional outcome, no caregivers. Lot of patients we have in our country like this. Best form of palliation to palliate the pain, put in a Ryan's tube, if required, do a tracheostomy, and palliate the patient on symptoms only.
Thank you. Point well taken. So the next question is for Dr. Neha Mittal. So what are the newer tests being performed on biopsies like PDL1? So you had mentioned about newer testing, punch biopsies, and how are they likely to be important for treatment?
Yeah, thank you for that question, Dr. Narayana. And there are a few newer tests, but I would also like to take the opportunity to highlight the newer pathology-related parameters which are now being reported in oral cancers. Like it pertains probably to the previous case better, that this is the first time AJCC has accepted certain pathology-related parameters which help you better prognosticate your patients. For example, depth of invasion, the worst pattern of invasion in resected cases. And these are important parameters which have been proven to be more important than actually achieving adequate surgical margins. So yes, in cases at least in which we have achieved a surgical resection, there are pathology related parameters which must be looked at and reported and included the report. In that context, tumor budding is also coming up as a newer pathology related parameter which should be incorporated in the reports and is likely to be very soon incorporated in the standards of pathology reporting. Coming to this case, which is in which surgical resection is not possible, and what we get as a pathologist is a biopsy. And we would look for alternative and palliative methodology of treatment, or the second line or the recurrent metastatic advanced setting of treatment. Then, as you mentioned, PDL1, yes, is worth doing and worth trying as a treatment modality. In that case, the JCO publication 2022, the result is out for the Keynote 48 trial. And it very clearly tells us that in less than 1% PDL1 positivity, it's an immunohistochemical based test, and in less than 1% PDL1 positivity, then there is no role of combining pembrolizumab with any of the modalities or pembrolizumab alone therapy. The merit is only giving these therapies in patients who have more than 1% PDL1 positivity by immunohistochemistry. So 1 to 19%, and then the other category is more than 20%. Maximum benefit, of course, in cases which are more than 20% positivity for PDL1. Certain points for PDL1, it is a companion diagnostic, PDL1 immunohistochemistry, which means that giving a particular drug requires doing the exact immunohistochemical marker which is known or which has been approved as its companion diagnostic. An example would be the companion diagnostic of pembrolizumab is the 22C3 immunohistochemical marker by DACO. Any other immunohistochemical methodology to do PDL1 is not considered an ideal methodology to report or treat with PDL1 based therapy in these patients. Similarly, we have other methodologies like SP263 by Ventana, which have their own companion diagnostic, nivolumab and all those others. So the companion diagnostic marker has to be perfect, though there are multiple studies which have indicated that the correlation between one marker to the other is quite good when we are talking about more than 1% and especially more than 10% PDL1 positivity using different types of immunohistochemical markers and methodologies.
Perfect.
If PD-L1 is less than 1%, then higher genetic methods like tumor burden, tumor mutational burdens, and certain T-cell related therapies are being, are being proposed, but those are mostly in experimental setting and very, in experiment and trial settings, and are not being used in the clinics as far as now.
Thank you. So I'm just going to put forth one last question, which I think I'll take. So what is end of life care in oral cancer? So in this patient who we saw, we know that we are not going to be able to treat them meaningfully. So when you know that cure is not an option, there are a few things you have to take care of. So one is to take care of oral hygiene. So you use mouthwashes, whatever dressing is possible. You need to take care of feeding. So either Ryle's tube or a peg, wherever possible. If the patient is at risk for aspiration, you may have to do a tracheostomy. You have to manage their pain, and then you have to look at any other risks that they may have in palliating appropriately. So if the patient has a risk of bleeding, you may have to give hemostatic RT, or you may think of interventional procedures. So the aim is to give them as painful and peaceful a death as possible. So even though we can't cure them, we have to think very carefully about palliative care and how to make them comfortable. So that's as much our role as operating on them or giving them radical treatment is taking care of them at the end of life. So I think we'll take some audience questions. So the first question is there any medication for puffiness of the buccal mucosa due to chewing tobacco for almost 4 years? Anybody want to take that question? So by puffiness, you mean, oral submucous fibrosis, or you just mean thickening? So usually we don't have very many medications that are effective. Usually tobacco cessation. If it's localized areas, you can do fibrotomies and things like that. People have talked about hyaluronidase injections, but not much valuable evidence on that. So I think the next question is, which biopsy is considered to be the most effective and precise? Anybody want to take that? Any of the surgeons? I guess not. So
Biopsy.
Please.
Hello. Yeah. So this is a very important point, as Dr. Neha nicely elaborated a few points on this. It has to be a representative biopsy. That's the first point. Now, representative biopsy can be from the part of the lesion which looks most suspicious. For example, if you have a lipoplexia, find out for the most indurated part, find out the part that is bleeding to touch, or the part that is painful to touch. For a lesion which is infiltrating, not much of a mucosal disease, the best sort of biopsy is an incisional biopsy. The submucosa has to be included, and you have to go deep down to the muscle to get a positive biopsy. Second option for a proliferative or an ulcerative lesion, a punch biopsy is a very good option. However, the problem comes for a very proliferative lesion where you may lot of keratinization, and you may end up taking deep biopsies with a punch, but that may not include the basement membrane. So in those cases, the best option is to go for another knife biopsy, take a deep knife biopsy, go up to the underlying muscle so that the basement membrane is always included. Not much of a role for brush cytologies, not much of a role for FNS in oral cancer. And for small lesions, avoid an excisional biopsy, because once you excise the tumor without margins and it comes out with squamous carcinoma or some malignancy, then again you have to go back and revise the whole area. So best option is not to do excisional biopsy for even a small lesion. If at all it is done, then put in a suture or something like that, so that the surgeon who is operating gets an idea from where the excisional biopsy was taken.
I would like to second that. Punch at our center, Tata Memorial Hospital, punch biopsy is the most common type of oral cancer biopsy that we see, and it suffices for most of our cases, barring few of the verrucous and the hyperplastic lesions in which a deeper knife biopsy may have to be resorted to.
Aditya, you want to add something? Please go ahead.
I may add to that. I think the big challenge that we face is those endophytic lesions where an actual proliferative lesion may not be visible. In that, even a punch biopsy may not be representative of the sections of the tissue that we want to assume. So in that case, in certain cases where it is possible or accessible, even a two-cut biopsy may be the need of the hour. So so a small two-cut biopsy, because in particularly in cases of the base of tongue where the lesions are not exactly proliferative in on every time, then a two-cut biopsy is often necessary, is what we have seen in our clinical experience.
Perfect. So I think we have time for one more question. So do we need to take the normal margin in the biopsy? So I'll hand that to Dr. Neha.
Yeah, so in an obviously malignant lesion, I don't think that is required. That is, in an obviously malignant lesion, the cytological features and the architectural atypia is enough to call it a malignant lesion. But for pre-malignant lesions or for early lesions, yes, that is definitely preferable, because the lesions may be subtle, and comparison with the normal, which is of that same patient, which is present in the biopsy, is it is helpful to diagnose these lesions and classify them accurately.
Perfect. Does HPV positivity affect treatment in any way? So in oral cancer, no. In oropharyngeal cancers, we know that HPV positivity impacts the survival, big impact on survival. But in oral cancer, it's possible that patients may be HPV positive, but it probably is not involved in the pathogenesis of the tumor. So in oral cavity, no, but in oropharynx, yes, of course. So I think that's it from the panel. Thank you very much. Over to the chairpersons for their comments.
Yeah, thank you, Dr. Narayan, for the opportunity. And thank you all panelists for a very enthusiastic discussion on the various points raised. I wanted to emphasize again what Dr. Neha has already said. We have to have a uniform reporting of both the cytology as well as the histopathology all over the country, in fact globally, so that we are all on the same page when it comes to a diagnosis. Secondly, I think Dr. Narayan has emphasized that there should be a cooperation between the departments, and that should be definitely it should be our USP, so that we all cooperate together to give the patient the best diagnosis. In addition, I would like to state there are some newer molecular techniques which have come up. One of them is, I have read a paper about 1.5 lakh cases they have done with RT-PCR, which they say similar to COVID. You can now put, I think it's London-based study, Queen Mary Hospital. And if such a thing exists, we should take it up so that we have a screening modality for all our community cases. So it's easier to do screening, and we have community dentistry departments which can do such sample collection, and we do the RT-PCR back at base and then get back to the patients. And Dr. Pawan, I think, emphasized research. I think I second that, being from a research organization. I'm from ICMR, so I would always like to encourage that research be done. It's an India-specific concern, specifically related to non-smoking, that is chewing tobacco. So we have to pay the most attention to this, and I would like everybody to, all the youngsters who are listening in, to take an active role in participation in this. Thank you so much. Over to Dr. Narayan.
Thank you. Dr. Shalu, any comments? I think mute. We're not able to hear you. No, still not audible.
Can you hear me now?
Perfect.
Yeah, I just wanted to say that I'm pleased to be chairing this session, and it was indeed a great brainstorming and informative panel discussion where we have discussed, starting from the clinical exam, giving importance to clinical examination, then the vital dye staining, the investigations, the histopathological examination, and the treatment part. So I think it was all in one, the session, and it was an informative for all of us as a chairperson, as a faculty, and even the students might have got a lot of information in this thing. Thank you.
Thank you very much. Over to you, Shruti. Thank you very much for a great panel.
So much. I think it has been a terrific, very excellent panel discussion we have had after the technical session. So now I would like to invite Dr. Alok sir again to give the concluding remarks for the day. So over to you, Alok sir.
My compliments there. Exceptionally interesting afternoon, I must say. We finished in time enough to have our evening to ourselves. We started out with very good talks on radiology and how to look at pre-malignant lesions. But what I particularly liked was how it all culminated in the future that we can anticipate with regard to radiology, with regard to AI coming in. I'm not so sure when that future will be on us, but certainly it seems to be something that we are moving towards. The panel was exceptional, run in a very gentle manner by Narayana Subramaniam and with a very young panel, but very knowledgeable, very up to date. Loved it. If there's something that I may add to it, I must say I'm very hard put to add anything to it. But in our own practice, with regard to the first patient with leukoplakia and especially with extensive leukoplakia, we nowadays tend to use narrowband imaging to try and localize the areas which may be more sinister and which must be excised. We may use it to choose which areas to excise in patients with very extensive leukoplakia. We would, of course, use a laser in our practice to either shave off or to coagulate those areas which are leukoplakic. With regard to the tongue cancer patient, in our own practice with radiology, we are now coming around to also looking at the distance from the neurovascular bundle of the tumor. Of course, that's something that has been brought out by the TMH group very recently in a very nice publication. And if the neurovascular bundle is involved, then certainly we would look at a compartmental tongue resection. Even otherwise, we have graduated to largely doing a compartmental tongue resection for all T3s and T4s and most T2s. And the point was raised that we should be looking at free flap reconstruction, which is, of course, the best option. But in our own practice, again, the infrahyoid muscle flap is turning out to be a great option for reconstruction, both for the floor of mouth and for the tongue. Beyond that, with regard to histology, histological parameters that are coming in for tongue and oral cancer, certainly the worst pattern of invasion is now pretty well established as a significant prognostic factor. Dr. Neha Mittal did say that it might be more significant than margin assessment. I'm not so sure about that, but literature is indicating to the importance of this parameter and to its equivalence to margin assessment. We tend to nowadays use the Brandwin-Jessler staging system, which incorporates the worst pattern of invasion, which incorporates the lymphocytic response to the tumor, and of course PNI. And we find that is very dramatically associated with both disease-free survival and overall survival. So exceptionally good panel, I must say. With regard to palliation, I would say that the one other option that we tend to use, and I'm sure everybody uses that, is to use nerve blocks for pain palliation. So if a patient has significant pain, a nerve block is often the best option in terms of pain palliation, especially if it's localized very clearly to the V3 nerve. So exceptionally good afternoon, great learning experience for me. Great to see so many delegates listening in very carefully. And of course, many congratulations to all who contributed. So thank you.
Thank you so much. I think we should have a big round of applause for all the faculty, the chairpersons, the panelists, and the moderators who had done an exceptional job in this E-Conclave for day one today. So we are now moving ahead and to the next exciting event for the quiz, for which all of our participants have been excitingly waiting once again. So for the quiz today, let me first announce the prizes which we're going to offer for the quiz program. So the first three participants, the first three winners rather, for this quiz competition are going to win scholarship programs scholarship for the certificate programs offered by Gujarat University and ICanCaRe on tobacco cessation. This is the advanced certification. The second set of participants, the 16 participants from 4th to 20th rank positions will also win scholarships, and we're giving them opportunity to learn through these processes. There are gift coupons which are given out by ICanCaRe to these 20 winners, and also 3 gift hampers will be given to the first 3 winners by Marji Foods. Now, let me give a quick brief insight about what this program is. The Certified Tobacco Cessation Specialist is an advanced program for tobacco cessation and talks about the data-driven and scientific processes for tobacco cessation. It has all evidence-based protocols which is incorporated and researched after dealing with numerous forms of tobacco use in the country in India. And this is driven by most of the faculty and experts in the industry who have really worked hard on this to design this protocol. So with this now, I would like to invite the quiz leaders for the evening, Dr. Dushyant Malik, who is treasurer from Foundation for Head and Neck Oncology, and Dr. Rashmi Shukla, who is senior consultant from Radiation Oncology Max Healthcare. Please talk about what this quiz program is and how it would be conducted for the next 3 days.
So thank you, Shruti. Thank you. So I'm just going to read a few instructions for this quiz. Am I audible, Shruti?
Yeah, ma'am, you're absolutely audible.
Okay, so a very good evening to all of you. So the rules for this quiz is there is online quiz will be conducted on first 3 day of the second International Oral Cancer E-Conclave for the all registered delegates only. So to win, you have to participate for all the 3 quizzes on the 3 days. The quiz will be have 20 questions on the theme of that day. Points obtained for all the 3 days would be added to select the winner. In case of the fastest timer of submission, total for the 3 days would be considered. Winners would be the highest and fastest total for the 3 quiz. Result will be declared on the last day of the E-Conclave, displayed on the ICanCaRe community page and E-Conclave website. All winners will get certificates, scholarships for CTCS, and top 3 gets gift hampers. So there are exciting gift hampers for all of you for the 3 winners. The winners can avail the scholarship in the next schedule online CTCS Conclave. Decision by the organizer would be the final and everything. So over to you, Shruti, and go ahead with the quiz. All the best to all of you.
Yeah, thank you so much, ma'am. And now I would like to invite the quiz master for the evening, Dr. Vasanti Jigre. She is professor of oral medicine and radiology from KLE Dental College. Madam is a consultant and reader then, and also co-author for the books Natural Oral Care and Dental Therapy. She is also an internationally certified life coach. Her niche areas are academicians and success coaching for women. So over to Vasanti, ma'am, to please instruct the audience and to begin the quiz program.
Thank you so much. Am I audible to you?
Yeah, ma'am, perfectly.
Yes, thank
you. Sorry, you got muted, ma'am.
Thank you once again. And at the outset, I would like to thank the organizers of this second International E-Conclave on Oral Cancer. Big thank you to Dr. Reena Gupta, Dr. Pawan, and also to you, Dr. Shruti. So without further ado, I would like to proceed with the instructions. As you're all aware, the participants and everyone, that the theme is Approach to Oral Lesions Redefined. And in keeping with that theme, we have the quiz for you today. So the instructions for all the participants are as follows. A link will be shared in the chat box and participants need to open the given link. So fill in your email and name first so that your response can be recorded along with your name. Start answering the questions and you're going to have a total of 10 minutes to answer 20 questions. Your questions are in multiple choice form and pick the right answer. And once you're done, you can submit your responses. The decision of the quiz master and the leaders shall be final. So at the beginning, all the participants will be muted and the chat box will be disabled so that we do not receive any prompts for answers. And the quiz will have to be submitted within 10 minutes of completion of the quiz. So the fastest and the highest scorer wins. And here is the link. You can type the link or you can scan the QR code that is given here. Dr. Shruti, you're muted. Are you saying? Are you trying to say?
Share for a moment because I'm going to put the quiz link on the chat box.
Yes, so the quiz link will be shared on the chat box as well. So here's wishing all the participants good luck. Question number 1. Oral cancer is a public health disease. Which of the following approaches can reduce the burden of oral cancer? Option A, awareness programs in schools and colleges. B, remote diagnosis using mobile health applications. C, banning tobacco and areca nut products. D, oral screening camps. E, all of the above. Question 2. According to WHO, which of the following diseases is associated with the highest mortality, that is death, in low and middle income countries? A, tuberculosis. B, HIV/AIDS. C, malaria. D, oral cancer. Question 3. What is the most cost-effective public health strategy in non-communicable disease control? Specifically, cancer over here. A, aggressive treatment. B, prevention. C, availability of cancer specialists in all hospitals. D, none of the above. Question 4. Oral microbiome signatures in saliva are altered in oral cancer. Option A, yes. Option B, no. Option C, no such studies are available. Question 5. The oral mucosal microbiome reacts with alcohol and tobacco to, option A, deactivate metabolites. B, form genotoxic metabolites. C, none of the above. Question 6. In a resource-constrained setting, for screening and early detection of oral cancer, this can be a useful and cost-effective method. A, mobile devices. B, oral visual examination. C, scopes. D, training of all health professionals. E, none of the above. Question 7. Save the Youth campaign. The SAVE is A, suspension, arrogance, violent, end. B, suspect, adhere, volunteer, end. C, sensitize, assist, volunteer, enforce. D, strike, act, volunteer, end. Question 8. All healthcare professionals should be able to perform an oral examination of tobacco users. A, yes, all healthcare professionals. B, only dental. C, only ENT specialists. D, only nursing and ASHA workers. E, none of the above. Question 9. Which of the following potentially malignant disorder is a chronic areca nut chewer likely to develop? A, leukoplakia. B, proliferative verrucous leukoplakia. C, lichen planus. D, oral submucous fibrosis. Question 10. WHO has a global policy for the control of betel quid and areca nut use. Options are A, true. B, false. Question 11. Which of the following site provides updates on prevalence of tobacco use and preventive programs in India? Options are Global Adult Tobacco Survey India. Option B, WHO. C, Global Youth Tobacco Survey. D, National Health Portal. E, all of the above. Question number 12. Chota Dana campaign promoting oral self-examination by patients is an effective method to identify early oral changes. Options are A, yes. B, no. Question 13. One of the earliest changes in oral mucous membrane in areca nut chewers is A, brown discoloration. B, black discoloration. C, chewers mucosa. D, lichen planus. Question 14. Which of the following oral lesions is a diagnosis by exclusion? Options are A, lichen planus. B, leukoplakia. C, squamous cell carcinoma. D, all of the above. E, none of the above. Question number 15. A simple and cost-effective method to detect oral potentially malignant lesions in screening camps would be. Options are A. Chemiluminescence tests, B. Colposcopy, C. Oral brush biopsy, and D. Vital staining. Question number 16. Effective tobacco cessation intervention would include A. Active motivation, B. Behavioral support, C. Comorbidity management, D. Drugs and medication, pharmacotherapy, E. B and D only, F. All of the above. Question number 17. Which of the following is a telediagnostic approach for potentially malignant oral lesions and oral cancer? A. Telestoma, B. Estomatonet, C. Oncogrid, D. None of the above. Question number 18. According to the Global Adult Tobacco Survey 2 in 2016, what is the percentage of adults exposed to second-hand smoke at home and workplace? Options are A. 0 to 20%, B. 21 to 40%, C. 41 to 60%, D. More than 60%. Question number 19. The most important reason for failure to quit is A. Nagging of the spouse or any of the family member, B. Not seeking guidance by specialists, C. Poor willpower, D. Difficult managing the cravings and withdrawals. Question 20. The only organization in India providing 360-degree care for tobacco cessation is A. IPS, B. ICS, C. ICanCaRe, D. WHO, E. FHNO. So here's a last question which is compulsory, number C1. Would you practice oral screening and tobacco counseling in your routine after this workshop? So the options are yes, no, I want to start a ICanCaRe Tobacco Wellness and Oral Screening Center, and the last option is I want to get trained in tobacco intervention. So that is it, viewers. That brings us to the end of the quiz, and all the answers will be available on the community page of Facebook, which goes by www.facebook.com/groups/ICanCaRe.
It has been put in the chat box. I would request that all the participants who are here right now, they just go to the group Facebook page, and they can join the Facebook page, community page, so they can remain tuned in throughout the sessions. So it has been, please go to the chat box, click at the link which has been given for the community page, and join the page. And you can mention here that you have joined here. Thank you. So this is the TrisCare instrument that has been put here, and there is a special discount for all those who are participants for this. So besides the various things that has already Shruti has said, that the scholarships, then you get the Maji products, and you will be also entitled for all the participants. A special discount code has been generated for you to get this TrisCare product, which is a mouth opener device for all of you at a special cost. Thank you. So I think we had a wonderful session. So anything, Vasanthi, you want to say something to the participants?
I hope the participants had as much fun participating as I had fun creating this quiz for them, and wishing you good luck. I hope you participate in the rest of the quizzes also, so that you are eligible to win prizes. So thank you to all the organizing committee, all those who are involved in helping make this happen, and for all your support, sir. So thank you once again, and best wishes. We have 2 more minutes for the quiz to close. So I request all the participants to make the best of the time. And That's it from me. And over to you, Dr. Shruti.
Yeah. Just to inform right now, we have got 71 submissions, and it has been a great participation from everyone who is here. Dr. Rashmi, who is the quiz leader, and Dr. I think Rashmi is here. Dr. Rashmi, you want to say
Yes, sir.
something?
Yes, sir. I just want to say all the best to all participants because we have very exciting prizes, and so they have to be present for the next two quiz for the coming 2 Sundays, so that they will get the chance to have the winner. So all the best to all the participants, and it will be a very exciting gift. So be present on the coming 2 Sundays.
Yeah, all the 3 Sundays rather, I would say. The last day we will have the quiz declaration of the results, which will be declared by Rashmi and Dushyant. And so we look forward for active participations and regular participations for the next 2 Sundays and the prize declaration on the last day. So I again ask every one of you to please join the community page, so you can remain tuned in. And that's the community page, which is actually we are doing a lot of activities on ICanCaRe, so you can be a part of it, and we can always be there for it. So I back to Shruti and Dr. Reena, who are the academic director. Dr. Reena.
Thank you, Dr. Pawan. So I'll start from the rear, closing up. So I think, Vasanthi, you did a fantastic job, and thanks to all our great participants. And we have such a wonderful response. We request that all of you should be there for all the 3 upcoming and the forthcoming, quizzes. And let's play together and have fun together and learn while we have fun. Thanks, Vasanthi, one more time. Our quiz master, our quiz leads were really very nice. Thank you so much. And we go back to the panel discussion. It was an amazing panel discussion. The panelists were just fantastic. We learned so much from each other. And most importantly, congratulations to our, the conduct, the way Dr. conducted the whole panel discussion was just beautifully done. And that was probably the highlight, that it was a smooth, beautiful, wonderfully way our panel discussions were conducted, and it just went from one to another and building the whole case up. So thank you for that, and thank you, Dr. Narayan, and each and every one of our panelists. Our speakers for the day were just amazing. We brought out so many perspectives, and thank you for being a part of this program and making it one more step towards redefining oral cancers, towards capacity building, because this is a concern which each and every one of us will have forever in our lives. And this is a fight we will have to go on fighting and winning it every time. It is going to be a war, but it is going to be a fun war too at the same time. Thank you so very much. And it's been great having all our viewers, and a big thank you to our esteemed guests, our faculty, speakers, chairpersons, moderators, quiz leads, quiz master, our wonderful viewers on all the different media that they are there with us through the end. And it's great to see you, Nandita. Hi there. And it's great to see you. Yes, thank you. Thank you so much. And wonderful to see so many of our CTCS specialists all with us on this platform, and so many other people who are going to join in. Have a wonderful evening. We'll close with 2 lines from Dr. Pawan, because without that, I don't think this closes. Dr. Pawan, over to you.
Thank you so much. And I think we have got so many people joining across India.
Sir, can I interrupt you? Can I say 1 line only?
Of course, ma'am, of course. Now it's an open session and everyone can say anything. So please,
I just want to congrats Shruti also, because she has given a tremendous energy and a vibrant energy to whole of the whole of the conference. So I just want to congrats Shruti also, and God bless you, Shruti.
Thank you so much, ma'am, for the kind words and the blessings. I'm sure with everyone's blessings, I can improve each day.
Yeah, you are the best. You are the wonderful. I am impressed with you. Over to you, sir.
Thank you. But only thing that I can say right now, if everyone can switch on their camera, we can take a group picture.
Yeah. So we'll have a few words from Nandita ma'am also.
Yeah,
Hi
Nandita,
from
she
UK.
joined from UK.
Sorry. Yeah, hi. And it's very nice joining back after July. I thought so. It's very good. And I was just saying to Shruti on WhatsApp that I would like to forward this to our MaxFax people as well and see whether it generates interest from them as well. So because it's very important, especially during COVID, we've possibly lost touch with diagnosis, and people are presenting late and everything because of the restrictions. So it will be nice for us to forward saying that in India such a big program is going on, and here the government is launching, the NHS England is launching a huge project about smoking cessation. So it's going to be very interesting to see what happens in the next few months, because they're launching it big time. So let's see what happens, and hopefully in July, if we get this done, I'll be able to update on what is happening here, how government is slowly trying to help us, or in the hospitals to do something. So that'll be something nice, and I'll forward this program to our MaxFax people and see whether and ENT surgeons to see whether they are interested, because that forms an important part of their routine.
Sure, Nandita, that's wonderful. And just to add here, for the people who are still there, we have got 80 people still with us. So just in the month of July, we'll be having our Tobacco Con, and that's going to be another big event, and that's focusing only on tobacco cessation. How to help, how to understand tobacco cessation. We have been doing this courses, the certified courses, which have been launched by within accreditation with Gujarat University, and we have been doing this across India with one single focus, that to train everyone in tobacco cessation. So I think we had a wonderful time, almost 3 hours. We were locked into our room and focusing on the screen and listening. Our eyes and ear both focused on the screen. So right now I think we need to take a break. So everyone, if you can just, whoever can switch on the camera, let us just take a simple
group picture. We're going to have a group picture. So on the count of 3, I'll request everyone to please switch on their videos.
Premjit, so nice to see you, Premjit ji. You have to be part of the
My video is not getting on. Shruti, my video is, I am unable to open my video.
I'll make you co-host, ma'am.
Okay, your name is there. So others,
now try now.
Yeah, everyone, if you can switch it on.
It's okay, it's not
Durga, so
opening.
nice to see you, Durga. Veena ma'am.
Dr. Subhashis is also there from AIIMS Bhubaneswar.
Yeah. Archana is there. Shruti, Ambika. It's so wonderful. We need to get more and more people connected. That's going to be there. So we have got now Urvashi also. Urvashi is from where? Urvashi. So nice to see you, Urvashi. Chandresh Verma ma'am from ICMR. So namaskar ma'am.
Okay, so I'm going for the group picture now. All of you,
just give me a minute. Those who are on the just Urvashi, if you can turn the camera. Yeah, I think that's it. That's wonderful. Yeah. So please go ahead.
Ready? On the count of 3. 3, 2, 1. Okay, one more shot. I think there were some screenshots on. One more time on the count of 3. 3, 2, and 1. I'm clicking the shot. Done. Thank you so much. Thank you so much, everyone. I think it has been a lovely, fantastic day, full of knowledge, full of fun as well. And let's meet on the same time. We're not going to meet at 3:30. We're going to meet at 4 p.m. on the next Sunday with more technical sessions and panel discussion, and the quiz to be taken ahead. Have a great Sunday. Have a great time, everyone. Thank you so much. Bye-bye.
Thank you. Bye.
Thank you,
everyone.
So great time. Thank you.
Thank you.
Usha ma'am, thank you so much for being here.
Thank you, Dr. Pawan. Bye, sir. Bye, everybody. Nice to be here.
Hi, Dr. Gupta. Thank you so much. Usha ma'am, thank you so much. Thank you, everyone, for joining in. Dr.
Thank you,
Subhashis,
Shruti.
thank you so
Bye.
much. Thank you, ma'am. Thank you, Usha ma'am. Thank you. I'm closing the meeting. Thank you.
Yeah.
Thank you.